you want to lead off?
Good morning, everyone, and thank you for joining us. I know we have a number of folks on the telephone as well, including our co-chair, Dr. Laura Herrera-Scott. Laura, I hope you are there. I'm sure she is. Oh, yep, we've got you, Laura. We'll make certain that we have time for your comments as well. Thank you for joining us on what is our last scheduled meeting of this group. We'll come back because we think we'd like to ask you for some additional help. We promise there will be an end to our work, but there's a little bit left to do, and we want to make certain that we have an opportunity to leave really giving the Health Services Cost Review Commission a good set of recommendations.
And it's so nice seeing everybody.
It is so nice to see everybody. Jean, what would we do otherwise, right? Thanks, Jean. Our agenda today, while it is extended, is again going to be quite tight, 50 pounds of material in a 10-pound bag. We're going to start this morning with a presentation by David Horrocks. David and I have had a chance to talk in the interim, and I think it will be extremely helpful to us to understand, given some of the things we've been talking about around the table, exactly what is doable and realistic as we think about the application of information technology to some of our challenges. We'll also be hearing from Dr. Howard Haft, and we're really looking forward, Dr. Haft, to your presentation. But what I wanted to do by way of introduction is make certain that folks see that 10:55 to 12:20 window when Jack Meyer will be doing his magic. We attempted to revise the opportunities grid. And remember, this is opportunities for Maryland investment in care coordination. Recall the immediate push is we do have some funding available in the state to apply to ways to accelerate and scale care coordination. And we really want to get through that set of recommendations today. There are too many to fund on that page. Our objective will be to prioritize and begin to make some recommendations about which ones we think float to the top of the list. And then closing out the day, wrap up and next steps. I think Jack's sole purpose today is to push us through that opportunities grid, and then we can talk about next steps in terms of a report. But that is what we have planned for today, and with that, if I could please turn it over to Jack.
Thank you. I'm going to dispense with any opening remarks. I'll lead off the session with a minute and a half of opening remarks. But I did want to apologize in advance. There's been some, I guess for some of you, misunderstanding about the start time. We're really sorry about that. We had 2-3 weeks ago had to change from 9 to 12 to 10 to 1, and it was sent out to you. But I know that if you're like me, you originally got the invitation for 9. It goes on your calendar, and you might not have seen the adjustment, so that's happened to me, and I particularly apologize to Laura for the misunderstanding. I'll try, as the airline pilots say, we'll try to make up some lost time. I'm never sure I want them to do that. I mean, if you're supposed to go 650 miles an hour, don't go 700. But I will try to get you out of here a little bit earlier because I know some of you have commitments in Annapolis and other places. So we'll do the best we can to tighten up after the facilitated discussion. That said, David, the floor is yours. Let's make sure David's slides are up, and we'll go from there.
Jack, thank you. Thank you, Carmela, and Laura as well, for the chance to talk about. I'd like to talk about the ways I think CRISP can support the care management efforts that you all have been talking about. I want to take just a minute at the beginning to describe CRISP, and I know most of us are familiar with what CRISP is to a degree, but I want to just bring a little nuance to what the organization is. First, thanks. As an organization, we were chartered to improve health and wellness through health IT that is best done cooperatively. Now, of course, most health IT is not doesn't need to be done cooperatively, but those things that need to be pursued with the input of many stakeholders, that is the reason that CRIS was chartered. Our governance structure is designed to bring stakeholders together for prioritization and decision making, and we have, including many of the people here, we have 4 board members who are involved in the care management work group. I want to just call out something I've heard about CRIS that I think is a misunderstanding. I have heard people say, should we use CRIS to do this, or should we use some vendor? And it's important that everyone understand that that's a false dichotomy, that when you say, let's do something through CRIS, that generally means we are going to do it with another vendor. I heard someone say, should we use Optum or CRIS? And it could be that we would do both, but not necessarily Optum. But we work through partnerships and contracts, and the structure of the organization allows us to come together and figure out who is going to do the best job at a particular task. And so I think that's important to say. One other thing I want to say about the organization before I jump into this is, if you look at our guiding principles, the first one is about manageable scope and remaining incremental. And we like to be incrementalists. And I know that's not always possible. There are times when you have to take a bigger leap. But 3 of the 4 founders of our organization were health system CIOs. And they just are oriented towards being pragmatic and approach projects with the mindset of what can actually be achieved. And that is part of our organization, thinking about what we can actually implement and achieve. So that's my little background. And I'll jump in on slide 3 with that spirit of pragmatism. That's how I want to describe the ways that I think CRIS can build on existing capabilities to support your care management efforts. I'm sorry. This is my own simplified understanding of the plan you all are developing, recognizing that there are details to work out, but I can't discuss the technology to support some of these things unless I have a general outline in my head. We're going to try to identify high utilizers among our Medicare beneficiaries, try to associate those folks with the physicians who care for them and with the hospitals. Then we'll encourage some care management from the hospitals and from the physicians. We will ask folks to have some elements of a common care profile or care plan, and if we can do it for a small subset, we perhaps will try to expand. So I hope I'm kind of getting the big picture right. Well, rather than think about CRIS services, though, from the vantage point of those individual steps in the process, I thought it might be better to come at it from the vantage point of the venues in which health information can be useful. And generally speaking, I think there are these 4 venues. You can use information for the statewide reporting and things we would do collectively that are prior to the point of care. Second venue is at the point of care. This is what CRIS really started focusing on 6 years ago. How do we get information into the hand of a clinician when a patient is right in front of them? Then there's a care management activity, which may happen when the patient's not even with you. And then the 4th would be engagement with the patient, him or herself. So, and the reason I think this is a helpful way to think about CRIS services is that fundamentally we help stakeholders move and use health information, and these are the venues. So the first of those is the statewide setting. We're going to identify people who would benefit from interventions. I think the first thing I I want to say is that we already have, we've spent a lot of time talking about Medicare data. We already have a good amount of data as a state that can be used for this purpose. We already can use the case mix data that HSCRC collects to create reports of high utilization. We can do it first just with simple cost numbers, and that can be done today. There is an issue of data use that we have to work through before those can be distributed to the people who need them, and a patient consent process. But I want you to know that we can do that today. We could create these reports. We could put them on a monthly schedule for every hospital and for every ACO or practice who needed them. We could also use that same data to create a more sophisticated risk stratification system and risk scoring system, again, on the case mix data. And we would just need to contract with the right organization or bring in the right expertise to get that done. But much of that work, I don't know if it's an 80% of 100%, but much of that work I think could start with the information that's in hand today. We also could make good progress on patient relationship identification, certainly with hospitals, again, out of the case mix data. But we also have, through CRISP's existing encounter notification service, where physicians provide to us a panel of their patients so that we can provide notifications then. We have a certain percentage of the Medicare beneficiaries identified with a PCP through that, and perhaps it's half of the beneficiaries. We could figure out who they belong to. Now, all of this, of course, could be done more accurately and completely if, as a state, we obtain Medicare data. But I did want to make that point that I think much of it can be done today. This is an example of a report that we can create right now out of the data. Perhaps it goes a little more with the next slide. This is could be used at the point of care, or it could be used in that risk stratification process. But it's a report on patient full utilization across all hospitals. Okay, second venue is the point of care. CRISP's first mission was to provide that richer information to clinicians at the point of care. So I'm particularly excited about this set of opportunities. And I will say that these are all, I characterize these as extensions of existing capabilities, and they can be pursued incrementally. The first of these is just creating a simple visit list, showing the recent treatment encounters, not just hospital encounters, but ambulatory encounters and other care settings, so that when a clinician at the point of care has a patient in front of him or her, you'll understand where services are being received, when they've been received, and how recently. With that, we can do a much better job of clinician relationship identification and put that right into our clinical portal. You have a patient here, you understand who this person's PCP is, and then using the provider directory, which has been assembled in the state working with the Health Benefit Exchange, we can have the contact information for that provider as well. So you have someone in front of you, you know who they belong to, and you know how to reach out and contact them to facilitate care coordination. Fourth is to put a care profile right into that portal. And this is standards-based and displayed, in some cases pulled from a more comprehensive care plan. And there's more detail, certainly, that we could talk about with what a care profile should look like. But in concept, getting this simple summary information into the hands of the clinician as they're making treatment decisions is the concept here. And the fifth, and this is a little bit more complicated, is an in-context alerting mechanism. That is to say, you're only halfway there if you assemble all the information that a clinician would need. The second thing you need to do is make sure they know to go grab it, that they know it's there. And so we need a mechanism when someone, let's say, shows up in an emergency room, that the clinician's there get alerted, well, this person has a care profile or care plan, or this person is on the care management, part of the care management program, and there is information, or this person's PCP is asked that we call if they come to the hospital. That simple notification, I think, could go a long way to promoting care management. The most difficult part of this is getting the ambulatory connectivity you need to assemble the data, and we're working hard on incremental approaches for this. I'd say even opportunistic approaches to ambulatory connectivity, but I believe it's very much accomplishable if we do commit to it. Lastly, on this point of care venue, I want to say that as a state, we already have processes for credentialing people to use information. We have 5,000 clinicians who've been credentialed who use this information in small ways today. And I think that's a great basis on which to build. We just need to get more complete information and get them using it perhaps more consistently for those Medicare beneficiaries where it's going to be most advantageous. We, as CHRIS as an organization, we are guided by clinicians in our community when we set these services up and design them. Our clinical committee would guide this process. Dr. Kellerman chairs the clinical committee. Dr. Carter's been on that clinical committee since its inception 5 years ago as well. And this is just the picture of the existing clinical portal, and it's very customizable, and you can imagine adding new elements to this sort of default view to facilitate this process. Third venue is care management. How can CHRIS build on what's been done already to support care management? I think first and primarily, we can feed relevant information to those providing care management services to be used within their own tools. So moving the information and feeding it to the routing information, if you will, I think is the first and primary support that CHRIS should provide to the community. Now, as care plans and care profiles are created, secondly, I'd say that it wouldn't be hard to, at the point of care or for care managers, make those available and present them for viewing within the structure that exists. That would be a very incremental and easy step. The creating is a little tougher, but once it's created, getting it disseminated to those who need it, the platform already exists. If a standardized health risk assessment is being used, the same thing could happen there. It would be, once those things are created, it's very easy to make them available back out to the community. So the fourth bullet here, the functionality to generate a common care profile statement or agreed upon common elements of a care plan is not, that's not as simple, but that's also doable. As the standards, the national standards have begun to develop around both care plans and around structured documents, it would be possible for us to say, here are the elements that we're all going to agree are important and that we are going to all create in our different venues. And we could facilitate that process. It's becoming more realistic. I think a couple of years ago it would have been very hard to pull off in different systems, but it's becoming more possible. What is harder is the ability to edit a common care plan. To say, well, here's one that was created at one hospital in Epic, and now patients in front of a doctor who uses all scripts, and they're all going to edit that same document. That's much harder to pull off. But moving those common elements, I think, can be done. And there are ways that I believe we can especially for the smaller practices, facilitate this. There are many care management tools, but just installing a tool is insufficient. You need the connectivity and feeding all the right data, and I think that takes quite a bit of work. I believe we should look at ways we could package this up for especially the small practices, not the large institutions who have their strategies, but for everybody else. And if we focus our efforts on a few of these tools, I believe we could get the data moving in and create workflows, perhaps tied in with that TCPI grant, which you may have heard that as a state we've applied for. So I know much work would have to be done on this, but I am really optimistic about the potential to do those things incrementally. So lastly, patient engagement. Other than a small pilot that we have done in long-term care, CHRIS is not doing anything to directly engage patients. We strongly prefer to be sort of back-end support to clinicians as they engage patients. Now that said, there could be some things that we say should be done cooperatively to support patient engagement. And patient consent is one of those things. I do think we need a statewide patient consent platform. In fact, we already have one at CHRIS. It is relatively basic and simple. It needs to be made more sophisticated. But I strongly believe we need that. If we push management of consent out to all of the different care settings, it's going to be a complication and a burden that we don't want to place on our providers. So to the extent we did do those things, I'll also say that we would prefer, again, to expose those services through providers' own portals. So those are the venues and in general, the ways that I believe we could support this process. This is a diagram of ambulatory connectivity, and I'll just say that in routing information and moving information, there are a few steps, the actual routing, of course, but also data normalization, the consent management, and patient relationship determination. This is our vision, as you can see, getting information from ambulatory practices, moving them to the tools that health systems may already have, or moving them to some shared tools. You can do both. And I think this flexible, pragmatic approach is what we'd like to do with ambulatory integration. Lastly, just have a slide on our governance. You can see some of the individuals who are involved in guiding our work.
Thank you, David. You are indeed the pilot who gave me back some time, which I appreciate, and a very concise and informative presentation. I'm going to move right on. I'll allow a couple minutes for questions, but I first want to call on Dr. Howard Haft. Howard has put a lot of thought into all the issues that David talked about and into care coordination and collaboration. And so we've invited Howard to share some of his suggestions with us this morning before we go into a facilitated discussion. So Howard, please, the floor is yours.
Jack, thank you very much. And I really appreciate the time that you've given me, and I hope that it's meaningful for everyone. I started perhaps 4 years ago every Thursday meeting with care managers. And initially it was care managers around PCMH, Patient-Centered Medical Home Project. But soon it became care managers around a few different patient-centered medical home projects, the Care First single payer, the multi-payer state program. And then that group kind of grew from there because we found that there were people in the community that we needed to deal with on a regular basis in order to really affect care management, which is at the heart of patient-centered medical homes. So we rolled in care managers from a local hospital and then another local hospital representing University of Maryland, representing MedStar, representing an unaffiliated hospital unaffiliated with any other large system, and then rolled in others, folks from community resources, from SNFs, from medical gyms in the community, from pulmonary rehab programs. And over the 4 years, that group has grown to be now a little bit north of 70 people who either show up in person or log in on a WebEx and a conference call every Thursday and share information. But I have to tell you, this sharing of information is very, very rudimentary. We do it, with tin cans struck together by wire. We do it with faxes. We do it with little Valentine notes that we share between each other. And the root cause analysis of why we do it that way is that all of us represent, in some way, shape, or form, some institution that has at the heart of it some very, very smart information technology people and governance who have built some wonderful, wonderful defenses against information ever escaping and being shared outside of those institutions. I mean, case-hardened walls and machine gun implementations at the top and razor wire around it. So it's really hard to share this information from one to another. But we figured out ways to do it. But I have to tell you, it's Rube Goldberg-ish, the way we share information. And it's absolutely not scalable. What David has is thoughtful and scalable, the health information exchange. What we cobble together is what people do at the ground level when they don't have any other resource. And I have to tell you that I brought to this group over the last year the good news that comes out of the hopeful talk that comes from this group and from the groups that preceded it about initiatives and a willingness to be able to break down those barriers and create real communication across all the continuum of care. And yesterday, when I happened to, your agenda is, of course, public knowledge. It's up on the website. So we put up on the WebEx the agenda and some of the elements in it. And it brought tremendous joy to this group that other people elsewhere see this as a big problem and that there are solutions that are in the future. And I just wanted to talk about, from my perspective, what some of those things might be. And I really think there's really 4 key elements, and I just really probably mirror a lot of what David just said in his presentation. And the first part of this is the how, and how do we share information? How are we going to do that? And it really has to be through some health information exchange, and we're fortunate in this state that CRISP has already been established, and we just heard about the things that are already within the capabilities of CRISP. More than just those capabilities that exist now, it's a platform to build more on, and really the easy on-ramp and off-ramp for information for a lot of different users of information. And that's what we don't have now, a place where we can get on the information highway and then get the information off. We have instead these roadblocks. CRISP provides us with that ability to do that, plus a lot of other things. It provides us, if you really think about it, the thing that has really made everyone really itchy about sharing information is it's confidential stuff. It could be hacked. And that's the last thing that anybody wants to have on their watch is have all their healthcare information hacked, and now it's in Russia and China, and people are doing whatever they do, whatever the heck they do with that stuff. But it's confidential. It shouldn't be shared except for those people who need to get it. And that's why we built those barriers, and they're appropriate. But the vision for HL7, the vision for all of us, is that whoever needs to have that information, if the patient is consented to give that information, it should be shared. But there needs to be some controls over that, who can get the information, and there needs to be some kind of public utility that governs that. And CRISP has the ability to do that, to sit at the center of it and say who can get the information. Let's verify credentials. Let's give certain permissions. That needs to be in the system. But I think that's there. The how it can be exchanged, we've heard abundantly that we can do that. There's some issues, but there's no real technological impasse to, if we want to exchange information, to doing that now. The Internet has enabled us to do that. The second thing is the what. So, okay, if we can exchange information, what do we exchange? I think, again, I think most of that early work has been defined. HL7 has said we're setting standards. It's done in a very collaborative way, and the ONC has established CCDA architecture in which we can package those standards, and I think Hl7 releases, and you have to correct me on this, I think in the early March, an actual document that looks like what care management might be, and for a static document and how that could be transmitted and those sorts of things. So a lot of that work has been done. It probably still needs consensus about what's really important to be in that document and what's editable and what's not editable. And that work needs to be done. It's not easy work, but it's work that's within our capability if we have the will to do it. And that, the core of it is very simple. We want everyone to know, for our patients, the basic things that they would get in a clinical summary document, something that describes them in terms of their demographics and their problem list and their medications and their allergies, and something that the patient can verify, kind of along the lines of the Blue Button Initiative, and say, yes, this is in fact me, and share that among their providers and adjudicate that document. But the what is pretty much there already. We just have to standardize it and agree on what it is. And it doesn't need to be boiling the ocean. It doesn't need to have all of the information. We all know at ground level, we don't need pages and pages of information. In fact, pages and pages of information cause overload, and we don't want to look at that. We just really want to look at the key elements, and we can boil those down. It may be a little different between different providers about what they agree or what's important to them, but that kind of nuance can also be baked into these kinds of documents also. So that's the what. The next thing is the who, and I think David again pointed out the who is our patients, of which CRSP already has several million in their database, but there's more than the who. The who is really the consents. It's not, because nobody enters into our world unless they enter through our door, and they only enter with their consent and our mutual consent that we're going to take on the fiduciary responsibility for them. And that's really something that happens every day at ground level when somebody walks into a provider's office. They've entered into this kind of compact. They may not have yet signed a document that said, in fact, they probably have signed some kind of permission that says, I can share my information with others who need to be shared within the realm of what's reasonable, but we're protected outside of that realm. But we're talking now about a more specific consent. And I think we get a lift again from that consent piece in that the federal government, that CMS has said, as part of our vision for the future, we want to encourage people to do care management. And it doesn't need to be just, we're not going to pay, it doesn't need to be, and we're not only going to just pay for face-to-face interventions. We're going to pay for non-face-to-face care management in a sufficient amount that there's an incentive to do it. Not trivial, not something that, why would I want to do that? Because it's a lot of work and I'm not going to get any return on that work. But, with this new chronic care management code, there's a sufficient incentive for providers to engage their workforce in doing that kind of care. And that demands, at the very beginning of it, that the patient consent for this process. And they have to consent also, as part of their process, that their information will be shared between and among people that are in the care system. So the consent is kind of baked into this chronic care management piece that now exists, that we're not utilizing to any great extent because it just started in January, but gives us a great opportunity. More than that, just consent. I think it also gives us this piece that says engagement. Because if you have consent but you don't have somebody who's really engaged in the process, it's pretty meaningless. But if the provider is engaged in it because they need to be and they want to be because it's good and they're also compensated, and the patient's engaged because they've signed up on this, and they have a little skin in the game too, they have to pay a little bit to be involved in that process, it fosters engagement. So it's a win-win situation, I think, by leveraging what exists, again, already there in the CCM world. And there, just in terms of scale, David already has lots of things happening in scale with what exists in CRSP. But when we look at the workforce in Maryland, we have about 6,000, according to the AMA database, 6,721 primary care providers who service 827,000 Medicare eligibles, which is about an average of 150 Medicare eligibles per primary care provider. Now, not every primary care provider sees the same number. Internists see a little bit more, family practice a little bit less. This number excludes pediatricians who see very few Medicare eligibles. But the point is that this is a doable project. I mean, to get a primary care doctor to engage 150 of his patients over the course of a year, signing consents and entering the system, that's not a heavy lift, particularly if it's associated with a significant revenue that's not associated with face-to-face encounters, doesn't cut into my schedule. And I won't bore you with the kind of the mechanics of primary care practice, but it suffices to say that it's a win situation. There's, you know, I think if you can expose primary care providers to the benefits of this kind of program, engaging in a chronic care management program that's facilitated through CRISP and has some tools that we can, as David said, that we can help provide to those providers in a workflow that we can train them through a PTCI grant, you begin to have a winning combination. And I think we're really fortunate now to be in a time and place where we have the concurrence of all of those elements together in an atmosphere where we actually need to do this, not only want to, but need to do this. And the last piece is in here of the four is sustainability. No program is worth doing if it's going to be supported by perpetual grants without being able to stand on its own 2 feet through some kind of sustainable funding mechanism. And again, I think that the wind is in our sails there because we now have kind of an already existing framework for funding through transitional care payments, through annual wellness visits, and through this chronic care management payment system that CMS has. Let me just tell you what happened with annual wellness visits, just to give you a note of reality that these things, that I'm not just blowing smoke here. So a few years ago, CMS came up with an annual wellness visit. You could get a certain amount on, I think it's $162 for a non-face-to-face visit, but it needs to be done in the provider's office, using staff primarily to characterize Medicare recipients as to what their gaps in care are and what their health risk assessments are and fall risk and depression, group of things. It takes about 20 or 25 minutes to do, more or less. In the practice that I provide consultation to has about 10,000 Medicare patients, maybe 12,000 now, more or less. I look back to see how many of the annual wellness visits were done. It's easy to do from looking at our claims data, how many claims we submitted, not how many were paid for. So 12,000 patients are about 150 annual wellness visits. And so presented this as a program to say, you know, we can incorporate this into workflow. We can utilize staff who are already existing without any significant increase in costs. We can benefit our patients, and we can benefit the practice overall, provider, knowledge, whole host of win-win-win situations. 1 year after doing that, 5,000 annual wellness visits, 150, 5,000. Simple. The math is simple when the incentives are immediate, as these are. You do something, you submit a claim, 14 days later you get paid. That's an immediate return on your investment, an immediate reward for an incentive. That's in the CCM codes. All of these non-face-to-face codes, which support care management, are I think the sustainability factor. So I think putting all those things together, I would say that nature reminds us that that evolution will continue to happen, and that evolution happens most quickly when there's a dramatic change in the environment. So dinosaurs were wiped out, only if cockroaches survived because they were able to adapt to that environment. So the survivability depends on our ability, when the environment changes, to adapt. We've had just this major change in our environment. So we will either adapt to it now or we won't, and we won't survive. And I think the adaptation has to do with making these things now happen, make this part of the fabric of what we do going forward. And history tells us that great innovations don't happen because some smart person comes up with a brilliant idea de novo and there's an innovation. It's a collaboration of a lot of smart people putting a lot of different ideas together into one box, and I think that's what we've done around the table here with David and all the other folks who have been here. And the economic truth is that nothing really survives unless it has some value that it brings to the enterprise overall. And the Jesuits have told us time and time again that mission is really important, but if there's no margin, there's no mission. And here we have, I think, both mission and margin together. So I think my suggestion, if I have a single suggestion, this is a great list of things that we're going to go through, that Jack's going to lead us through, and there's a lot of really very valuable projects that we actually can do and feel at the end of this journey that we're on for the last 6 months or so that we've done something successful and moved the needle forward in a major way. And I'm proud to be part of this group. Thank you very much.
Thank you very much, Howard. That was compelling and fabulous metaphors. It's nice for me to know in the world of texting and Instagram and selfies that 70 of your best friends and colleagues actually sit down every Thursday and talk to each other as real human beings. It's very comforting and very productive, I'm sure. Thanks for keeping that going for 4 years. Let me pause for a second and see if Laura, if you want. If not, you can chime in later, but I know it's hard to be on the phone listening. If there's any reaction you have, Laura, or comments on what you've heard, please jump in. Oh, okay. All right. Well, if she comes online, tell her I said that. To give me a shout out. To give me a shout out at any time. Thank you both. Are there any questions for either David or Howard? Yes, Lori. Or comments.
My question is for David, and first I'll thank you for Chris, because we use the ENS and we use Chris all the time to find out what's going on from our psychiatrists, who really are the PCPs for the people we serve. So did I hear you say that there could be other people put into the system so that, for instance, if one of our folks goes to the ED, we'll find out about it next day through the ENS system. But what we don't necessarily have is an understanding from the ED people that we're working with that individual, that they are with Mosaic, for instance,
right,
and that we're working. So could it be that they're showing up as also with Mosaic or with our nurse care manager? Because the ability to share information very early on, if they get admitted or even not, is critical. Sometimes changes are made in the hospital, like someone's put on a injectional diabetes medicine, and the individual has no one to help with that when they come back out, so they're going to quickly readmit. We could start training them, setting up a program, that kind of thing. So I was just wondering if that's what I heard you say.
Yes, it is. So for those who don't understand how ENS works, as Lori described, when we receive a patient panel from a PCP, we send, and we see one of their patients shows up at the hospital, we send them a message. Now, we can do it in real time, but for most practices, they prefer to receive it like 6 a.m. each morning for the prior day. There's two elements to this I think we can do. First is we could take a subset of your panel and say, well, for this smaller subset, we can send a text right to your clinician's phone so they know that one of the patients who is at risk and is on your critical list, let's call it, was just hospitalized, and do that in real time. The second is, yes, let's put in our portal the name of that clinician and contact information, and then send a special alert in the emergency room itself so the clinician understands, oh, here's someone who has a care manager who wants to be contacted, and it's more likely for that connection to occur in real time when the patient is still there receiving care. So, yes, you did understand that correctly.
That would be fantastic. Thank you.
Any other quick comments or questions? Oh, yeah.
In your presentation that we have 5,000 providers who are currently connected to CRIS. Howard suggested there are 6,000 primary care physicians. Can you just characterize the 5,000? And then from your perspective, if we were resoundingly successful in connecting the ambulatory world into CRISP, the total number would be what?
Okay. Of the 5,000 clinicians, Patty, roughly a third of the use happens in ambulatory settings, a third of the use happens in a hospital setting. That's actually a little bit more than the other two, and then a third is by pharmacists, and they make up the 5,000. So if you excluded, let's say, pharmacists, I know some pharmacists in rural places maybe serve a PCP type function, but if you excluded them, maybe you're down at 3,300, some of whom are hospitalists and specialists. So the number of PCPs is probably a few thousand. I think there are 2,500 primary care practices and 2,500 other practices, 5,000 practices roughly around the state. If you wanted to connect everyone, that's sort of the universe of connectivity.
For primary care.
2,500 for primary care. That's locations, actually. There, some of the some locations are commonly owned, but I guess that sounds right to me that if there are 2,500 locations and 6,000 providers, those would be the numbers. So this is very rough, but I'd say we maybe have a third of the primary care providers participating, all of the emergency rooms, but maybe only a third of the clinicians in the emergency room are using it. So those are round numbers. Does that answer your question?
Yeah, but there's also a whole group of specialists out there that are not practicing in primary care settings or hospitals.
That's right, much less. 2,500 practices is the number I've received from MHCC.
So to the point made I think we have to really understand the numbers, but to the point made by David that it is heavy lifting to get the connectivity necessary to realize this vision, and that needs to be fully appreciated.
How many doctors are there in the state then? 40.
So we would probably operate on, for this group, 15,000 physicians in active patient care in the state. So in a optimal healthcare system, you'd like a 50-50 relationship between primary and specialty care. Maryland, like the rest of the U.S., has more like a 35-65 breakout. So there's a lot.
That's not counting the specialists who are doing primary care, because there's a lot of specialists who are specialists and listed as specialists, but they are doing a hunk of primary care. It's not as bad as I think you just said.
But I really just wanted, I didn't want to ignite the conversation about the primary specialty, but I just wanted to, to make the point that there's a lot more doctors to be connected and patient care management information to flow than just primary care. So it's as we start to develop budgets, we need to think about what's it going to take to get our doctors connected, what's it going to take to get our mental health providers connected, what's it going to take to get our long-term care facilities connected, and we need to come up with a budget to do that, and that's one of the questions that we need to say, is this what we want to do? And if this is what we want to do, what's it going to take to connect them, and what's it going to take to do some of the things that David has talked about, and what's the annual operating budget going to be for that service? So, just to put it in my perspective, if we're spending multiple billions of dollars statewide on electronic health records, what's it going to take at the CRISP to make the transfer of information useful and valuable? And it's not the budget today, it's a much larger budget going forward. So that's part of the conversation we need to bring out of this, I think.
Okay. Based on people grabbing their little mics. I thought I saw Mark. No, and Ernest. If you have comments,
So just to quickly elaborate on what Donna just said, when we talk, there's a technical component of connection. Right? There is, at the highest level, Hl7 interfaces between all of the different electronic health records and CRISP, which needs to be built at both sides and tested at both sides. That has been the major problem with connecting ambulatory practices to date, because that cost has to be borne somewhere. And we are exploring less expensive ways of connecting, potentially through CCDAs that go via direct secure email, but those have a transaction cost typically, the way that most of those are built. And we have to factor in the transactional costs, which tend to be operating costs rather than capital costs.
okay. Thank you. I have Ernest, Steve, and then Carmela, and then we're going to go into the facilitated discussion. Dr. Carter.
Mark said exactly what I was going to say. I mean, we were thinking the same thing at the same time. The only thing I'll add to that is that's a huge barrier. I mean, because nobody wants to pay for that. I mean, and from all across the nation, but particularly the vendors don't want to pay. Nobody wants to pay for that, and that's a huge cost. So it is a big problem. It's the biggest problem that HIEs face, I think. I mean, other than some other things. So I just wanted to be sure that's known. That is the cost. If somebody has to make a commitment to how it's going to be paid for, and I know the primary care physicians that I talk to say, I'm not paying for that. And so that's the bottom line.
Thank you. Steve.
David, taking in mind what everybody just said about connectivity, to what degree is CRISP currently working hand in hand at a provider level with installed medical record systems?
In the ambulatory setting?
I guess in any setting. I'm thinking particularly hospital. Are there any places where where it's not operating in parallel as a separate system, but it's actually integrated in the?
But today, the best that we mostly do is integrate through a single sign-on, so that you're still going out to a separate portal when you view the information, but you're not logging in a separate time. You're not putting in a patient's information. And I think that happens at 8 hospitals of the 53 participating. But we are on track this year probably to put another 15 or 20 into that single sign-on setting. And that should make the workflow much easier. That in-context alerting that I described, that has to happen in the EMR or somewhere else. You can't have to go to a portal for that to happen. I do think in the long run, we view ourselves as moving the information and getting it ingested on the far side. The CCDAs and these standards, as those are perfected, I do believe more of that will happen. Does that answer your question?
It does, and wonderfully so, and I think it makes the point. And this is where CRISP has really, it has clearly been an emphasis over time, and CRISP has been remarkably successful in responding to concerns at the ground level, at the clinical level. In general, I think there's a public perception of clinicians as not happy with technology and not willing to try new technology. I think the reality is most clinicians have had dysfunctional technology shoved down their throats and have been very hesitant to have that happen again. No hospital had to be paid to install a radiology system, for example, because it works and people do it. It's great. People love it. On the other hand, we had to have a nationwide effort to spend money to get people to use EMRs. CRISP's greatest benefit is its accessibility. Its limitation is that it remains a separate sign-on and a separate portal. Anytime it slows down, the complaints begin. I start getting emails, which I forward to you guys. And it's very clear that that usage then decays. One of the benefits of CRISP has been that effort to do things incrementally, which has meant that it has never slowed to the point that the barriers at a clinical level have never gone to the point where people just stop using it, because that would be a death knell for the whole process. and it's very important to maintain that focus and effort that's been so successful so far to make it functional at a clinical level as we do this, that it remains functional at a clinical level. So, and part of that is saying thank you guys for doing that. That focus has really made a difference.
Great. Last comment.
And this may take us into the facilitated discussion. Thank you, both David and Howard, for your optimistic comments. My question picks up a little bit on Donna's, and that is, you both have said we can do this. Chris can do this. Dr. Haft, you were saying, we can make this happen. Could you talk then about the barriers? Because we're about to talk about one set of barriers, and those are financial. But I don't want to take us down that financial path if there are other significant barriers that we all need to be aware of. So, David, if you don't mind starting, but from your perspective of what you've outlined that Chris can do, what are the things we all need to really be aware of?
Sure, and I'll mention three things, and the first Patty I think already brought to the surface, and that is that the ambulatory connectivity is the heaviest lift. And we are looking at, it is getting easier though. Nationwide it is getting a bit easier. And I believe we'll have to take a very pragmatic approach to that connectivity. Multiple approaches, a little bit of catch as catch can, in fact. But it is the hardest, the biggest lift, and probably financially the biggest lift. The other two that I'll mention are that it's only half the battle to get a tool in the hands of a clinician. I think about ENS, there are some practices that use ENS to great effect. And then there are other practices who receive the information and do very little with it. And so there is what do you want to call it, a workflow training or a best practices that need to be disseminated, and that takes work. The TCPI grant, should we win it, is one way that we could address that. And then the third barrier, which you all probably understand better than I, but it's just been my experience that when the financial incentives for the providers are lined up with the things that the tool provides, adoption is much better. And if we are asking providers to do new things in care management with these new tools, I think that getting the financial incentives right is extremely important. That's huge. If we put these tools out and say, this is good for patients, please create care plans, and we don't line the other things up, it'll be a real uphill battle to get adoption.
Okay, thank you. Oh, I'm sorry.
So, yeah, three barriers. The first one David really spoke to in terms of the technological barrier, which I think also becomes easier with evolution of HL7, with the CCDAs, and as it becomes easier, it becomes less costly. But it is still, and Patty, you are absolutely right. It has to be factored in, and Donna, you're right. It needs to be factored in. You can't do it without making an initial investment. The two barriers that I face are the same ones that I faced all through my whole career, and that's provider engagement and patient engagement. So when I figure out the secret sauce to get both providers and patients engaged, we'll have the whole thing solved. But on provider engagement, really the answer is, just as you said, it's three things. One, as you said, you have to have the financial incentive. There needs to be an incentive that the incentive is given out soon after the action so that it matches up with the activity, whatever it is, and a payment system like Medicare works in that regard. It needs to be easy, so we need, things that are difficult, even if there is a significant incentive, become too much for providers to incorporate into their workflow. So we'll have to make this an easy on-ramp for people if we're going to make it successful. The good news there is that most of the lifting with these care management programs don't happen with the provider. They have to be the captain of the ship, but it happens at the staff level much more than it does at the provider level. So the on-ramp perspective from the provider is much easier than it is maybe from the staff level. But staff are trainable. Staff are very trainable. The last one, and really the most important, is patient engagement. And there we've got to show the patients, not just, I trust my doctor if he says that, I should do this, I'll sign up. But that there's really some value in signing up for this and paying, if it's a Medicare patient, $8 a month to have somebody call me and make sure that my blood pressure and my cholesterol and my diabetes are in good control, or whatever else goes into that mix. And those are really going to be the challenges. So the public needs to be educated, the providers need to be educated, and we need to be able to support the technology sufficiently with dollars.
Mark, last word.
Yeah, Jack, one quick comment, and this is sort of exactly leading into the consent conversation. I think we're going to have a potential barrier in terms of the regulatory language around authorization of sharing of healthcare records in the state. That if we interpret the regulations to mean that it's only good for 1 year and whatever consent process we develop, therefore, has to be renewed on an annual basis, that will create a workflow challenge that may be bigger than we can even imagine right now. In the HIE world, we deal with this a lot, and in the Epic EMR world, we're dealing with this right now. But I think it's something that we may need to really expressly focus on.
And could I ask a question, David? It may be to you. I've spent some time with the home health community on care coordination, and they have said, for example, that they are not, is it true, that they are not allowed to access the clinical information. And so some understanding of either the consent piece and who can and can't we share with. I know Amy spoke to this at our last meeting.
Go ahead, quick response.
And I think that's true. There are some limitations. Those are addressable when we have appropriate consent, though.
Okay, thank you. Again, thanks to both David and Howard for leading off today. I'm going to just introduce this facilitated discussion with a couple of quick notes. First, speaking of introductions, I want to introduce a couple of my HMA colleagues. Sitting next to Alice Burton, who you all know, is Dr. Greg Vachon at HMA in our Chicago office, and sitting next to Greg is she there? Oh, she just stepped out. Sorry. Well, it's Deborah Gracie. She'll be back in a moment. And while we've been all doing our day jobs, they've been working on filling in the details on. Actually, even while we're sleeping, they've been working on developing the content behind many of the things we're doing, and they are also now working on a budget for the investments that we're going to talk about today. We probably won't get into that really today, but we realize we're going to be talking about investments, and investments have to be financed, and they are working on that as well. I also wanted to point out and thank Carmela for taking an earlier version of this in opportunities grid and condensing it nicely into 4 domains. With your permission, Madam Chair, I'm in a moment going to ask that we discuss them as a group. There are 25 rows, and if we try to go into 25 rows, we would be the last 2 people here, and everyone would have left. So, but we can bring up individual rows, but we'll try to cluster them. So, and then my final comment is I jotted down a few themes that seem to pop out at me that maybe can guide some of our discussion from these 25 themes. First, one clear theme is, and these came from your comments at earlier meetings, use what you have and get what you don't have. And so you'll see that we're proposing a 2-track system. Many of you have made that point in earlier meetings. Second, common infrastructure, common elements, consistency of information collected, and even standardization of format. These create public goods for all of us, but I wanted to make the point that connectivity is not cookbook medicine. So we recognize that even though we can standardize the collection of information and the organization of information and the dissemination across providers, then in the end it's a physician seeing a real patient, and every patient is different. That's understood. But we think that there are efficiencies from some of these common infrastructure items that could help physicians, but not tell them how to treat patients. Third, we heard you on patient consent and patient engagement at the last meeting, and it came up already this morning, so we've included that. Fourth it's absolutely critical to identify people who would benefit the most from care coordination. You'll see that woven into the text of our document. Just two more. Fifth, obviously, avoid duplication, collaborate, avoid reinventing the wheel. Clearly there. And finally, what I would call bridge building and breaking down silos. Whether it's behavioral health and somatic health that need to be integrated, or bridging from hospital to post-acute and home care, or gain-sharing arrangements to build bridges between physicians and hospitals, or working with community-based organizations and bringing them in, all those bridges need to be built. So what I would suggest then with that as a quick backdrop is that we focus on what I'll call domain one, build secure data infrastructure to facilitate the identification of individuals who would most benefit from care coordination, having a care plan, having it implemented. And by the way, you will see that we picked up, Gene, on your suggestion at the last meeting to add an implementation strategy column. That was your idea. It was a good one. We've tried to do that. And all of this, and finally, and most important, and this is our attempt to guide, but your job to react, we've attempted to put X's in the columns where we think that it would make most sense to center these activities at the state, regional, or local level. So your comments are welcome on, did we get that right? Do you see it differently? Have we missed things? So this is a markup draft, but I do want to try to come to some closure as possible at the end of the day of, yes, we think this is a good set as amended, and this caveat, and yes, we like the X's here, or no, we don't. So let's work together to do that. Let's start with the first set of 5, and the floor is open for your reaction. This includes data acquisition and consent and the identification of high needs people.
So, okay, one quick question. So who the implementation stuff in here, who wrote that? Made those decisions? Because the only concern I have is that, like, in every one of them you have used BRFA funds, and it just seems to me that is kind of might be difficult given the fact there's like a grant out that has specific requirements, and hospitals and other community providers probably have ideas around them. And then on top of that, there's only $15 million in the BRFA fund, so that could be problematic. So I don't know how realistic that is.
Let me jump in on that. This is just a working document. It is what we do with it today. Places where BRFA funds are noted are places where money would be needed. But exactly to your point, what that column is supposed to force is we can't do all of this. And so what we hope to do today with this group's help is to say we have a limited set of funds. If we're going to do it, which of these activities rise to the top of the list?
I'm not against using them, don't get me wrong. I think that's a good use. Some of this stuff is a good use of it. I just, it seems to me like we don't have a lot of other answers.
That's what we want to hear.
Yeah. Okay.
Yeah, absolutely. I think I saw Ben first and then Pat.
Gene made, thinking quicker than I do, made the point. But I think it does have value. If you thought about this as really implementation is 2 stages, establishment and then sustainability. So if you can delineate that, most of what's spelled out here I think is really establishment. But establishment probably is not sufficient if there's no sustainability strategy in the implementation framework going forward. That was my observation. I think clearly the BRFA funds are an opportunity, but it couldn't establish all of these initiatives by itself.
Yes, there's a distinction between startup costs and operating costs. Good point. Thank you. Patty.
My lawyer coming out. I believe that we're trying to conclude a process. Is that fair? That either this meeting will end a process and then for purposes of then defining some new process. So it seems to me that if you're looking for consensus, then we need to be a little bit more thoughtful about going through this document. You have activities that I think you need to get consensus on, and then implementation strategies. So I would prefer that we do have some time, don't we?
Yeah, we have about an hour.
Because without going through it that way, you may walk away thinking you achieved something that perhaps you didn't.
Fair enough. And I would say that's a fair point. I don't want to make the perfect the enemy of the good. I'm not saying we have to have 25 rows signed off on in every column. And I think your point is well taken. From my point of view, getting some consensus about the activities at this point is more important than the implementation strategies. Heard some of the points that Jean made and others there. And I'm happy to go through row by row and see how many we can. So there was no attempt to slide over things. That's a point well taken.
To her point, can I make another suggestion? Sure. As we kind of go through these activities, we might have activities where we have consensus that's 100%. But it might be a consensus that's 100% where none of us really care that much about it. So we should also measure intensity as well, and how important, how much it moves the meter. So that would be another thing we could maybe kind of get out of this. And I do think there are a lot of other groups that are going to be interested in some of these that aren't listed at all in the implementation.
Yes.
I noticed that MedCat didn't make the list and implementation on anything on here, and we'd love to help.
Okay, we won't turn that offer down. Yeah. And I want to say, in response to that quickly, Jean and Patty, I don't want to make the perfect the enemy of good. Consensus doesn't mean that 18 people say absolutely yes without reservation on everything. It means what it says, that consensus is most of you think that, yes, this is going in the right direction. And there will be some caveats and so on. So I recognize that. No attempt to railroad this. Mark.
So I want to switch to get us back into the details, if I could.
Yeah,
so
please.
Specifically about consent, we have an opportunity, I believe, for a huge home run. We are going to require, I think, in getting the de-identified data from Medicare, some process for telling CMS we're going to get separate consent from the patients. Chris, for purposes of care coordination, is going to need to require a second consent, and CMS is going to require a second consent for patients to allow their providers to bill for care coordination services. I think if we do it right, we have the opportunity to get all three processes taken care of in a single consent, and then we can figure out the workflows. If the hospital care coordinators, where the consent initially happens, and they identify who the primary care provider is, we can communicate that information to the primary care provider through a mechanism. Could you tick the three off again for me? So permission from the patient to use their de-identified CMS data that I think is going to be part of, their identified CMS data. Permission from the patient for expanding the CRISP use cases to include a broader view of care coordinators, and again, I would hope for until they revoke the consent and not the Maryland, this authorization is only good for 1 year. That'll be a problem. And third, on behalf of the providers who are going to be billing for care coordination services, authorization from the patient for agreeing to participate in those services.
Okay, thanks. That is helpful, and I'm happy to get into the specifics, and that's a good lead.
And I would support I would support what he just said, and also point out the other benefit of that is, from our perspective, physicians, if we could make this work, it could be sustainable, because obviously the new CPT codes and billing opportunities would have an economic incentive to continue to do it if we could get it to work. I am a little skeptical about how well that's going to work from a practical point of view, having seen people deal with patients in the physician's office and how comfortable Medicare patients are in, paying extra money for care management. But that could create an ongoing source of funds, possibly. So I think that is one that should be a higher priority.
Okay, good.
I think that it really is a very practical suggestion too, because the typical Medicare patient will visit their primary care doctor 4 times a year. So they have lots of opportunities to get those consent signed. So in the course of a year, they'll see the majority of those Medicare patients, and that's a quick on-ramp to getting consent, and it bundles it all together. The key is getting that document correct and aligned with whatever the COMAR is.
Steve Boyd, a note of caution. One of the things, part of this would be a question for you, David. One of the valuable aspects of CRISP is its current process of opt-out as opposed to opt-in. and I wonder if setting up this patient consent process interrupts that. And I asked that more broadly too, and that one of the things HIPAA did over its first number of years was convince practitioners that they couldn't actually talk to each other, despite the fact that it expressly allowed practitioners to talk to each other. There was a lot of fear around that for many years. So, to just upset the apple cart for Chris.
Yeah, no, thanks for the question. I don't think it has to, but we have to very thoughtfully construct, I think, the consent processes, and with input from strong input from providers, but also from the patient advocates. There will be some additional steps, I think, that has to happen, but there are a lot of details to consent, and this is why I made sure to put in here we should have statewide consent infrastructure. If we try to manage this at each point of care, it will be a real mess.
Well, you read my mind, because I was going to ask if there was agreement that that our X in the state level column for this is appropriate. It seems you feel it is. I see some heads nodding. Is there general agreement about that? Okay. Oh, I'm sorry. I didn't.
You got to just yell. It's okay.
I'm sorry, Adrian. Let me set a policy. You may either raise your hand or put your card up, and I apologize for that. Please go ahead.
I think you were getting to where I was going. I was just going to agree with David that I think having a standardized statewide consent procedure is important, and I would add that as much as possible, if there is a way to standardize some educational materials and things that go around that, that would also be helpful. From a patient or consumer perspective, having multiple consents and having different information on each of those consents is really confusing and almost meaningless. And then I would, to Mark's point, I sit on the HIE policy board. I would maybe this committee or HSCRC or something could write something to the HIE policy board that there is an issue, that there may be an issue with the having to renew the consent every year. And so maybe that's something that can be addressed so that we can kind of align those things, because I don't think that is the intention to make things more difficult.
As a point of information also, and I think to be included in that discussion about consents, is that if it's at all possible to include consent that would also overlap with behavioral health, which has been kind of segregated out, that would be a tremendous step forward.
Yes, thank you. Ben.
That's an education issue.
Ben, you're next.
So I think giving some direction to the HIE policy board on this issue would be very valuable, in turn also as well as a framework for coming back with some recommendations on it. So we have some framework for getting resolution on this issue. The HIE policy board has is really well representative of interest in Maryland, but I think we'd want to, as the convener of the policy board, we want some encouragement to move promptly through this issue, getting all input, but making certain that we're not dilly-dallying.
Gotcha. Thank you. Carmela?
May I try a leap in the form of a chairman's mark?
You may.
And that is, I think Mark has put his finger, I think item number 3 here is one of the most important steps that we can take in terms of collectively accelerating our care coordination efforts. I would suggest that this first bucket among the 4 buckets is the most important bucket that we've got in front of us. Items number 3, 1, and 2, critically important. Item number 5, important, and 4 only becomes an issue for us if we actually secure the Medicare data. But I know we want to work through these line by line, but could I test that with folks, that this activity around securing data, organizing it, and sharing it is probably the most important thing that could come out of this work together.
Thank you. Agreed. Any comment on that? Or I think that's something we're probably in agreement on because we discussed at earlier meetings. Joanne?
I wonder if it would be welcome to expand the understanding of this category to include the opportunities for learning, monitoring, and managing the system. It seems that you want to have the data not only to ID the patients who need care coordination, which is what it now says, but also to see how we're doing with care coordination, to develop the time series and the monitoring that would continue to inform us as to which categories of patients are we doing well with and which are we not, or parts of the state that are doing well or not. And there's a lot of learning to come out of this data beyond identifying targets for coordination.
Makes sense to me. Others agree, Patty?
Well, obviously the general comment is, makes great sense. But I do think that as we think about this, we have to be thoughtful as to what this is going to accomplish. This will accomplish at some state level the opportunity to work a list with an undefined set of interventions, right? We've not yet figured out what we're going to do. And the evaluation work that you're referencing is happening all over the place at the local points of service in which care coordination is occurring. PCMHs are evaluating how their care coordination is working. ACOs are evaluating. Now, new hospital systems that are implementing new tools by virtue of the waiver are also considering evaluation. So I just would suggest that we need to certainly have a commitment to always be reviewing and evaluating, but I don't think this gets us to intervention, this document.
Agreed. And I think what we're trying to do here is gain the support of the group to go get it, organize it, synthesize it, and use it to identify people. You're absolutely right. Once you do identify them, you have to come up with individualized care plans, and that's not in this domain. I think we will get to that. But obviously, you don't get the data just to get it. You want to serve patients better.
Yeah, well, I don't know. I haven't left forward yet, so I'm not sure how far you get there. But and that's going to be very complicated.
Good point.
So to move us along, I would be comfortable in suggesting that, pursuant to kind of your prioritization, Carmela, of this domain, that I think that you have it right here.
Okay. Anybody? Oh, I'm sorry.
Maybe stating the obvious, but to Jean's earlier point, there is only, if you will, a fixed pot of money that we have available. But if we can identify the priorities, if we agree that this first bucket is a priority, we don't yet have the budget estimation to understand how much do we have left to spend. But I'm hoping what we can do is begin to rank order some of these so that we understand, as staff is helping to produce these budget estimates, how far down a list do we have the opportunity to go. Quite frankly, I don't even know if we get out of the first bucket, but we'll know that as staff continues to work this through. Thank you.
And we are working it. Okay, thank you. I'm going to take, but Mark, go ahead.
So we haven't really talked about this here, but when I think about identifying individuals who would benefit from care coordination, there is at CRISP and the clinical committee, we have thought about for a long time easier ways of getting laboratory data. So it's not a huge lift to get data from the commercial laboratories into CRISP. But because the laboratories identify their relationships with the providers and not with the patients or a broader statewide effort, they have been reluctant to engage with CRISP for that. But I think if we really want to get to a rich data source that's going to help us identify high-risk people at a relatively low lift, that's something that we might want to consider. I don't know how we do that, since we're not really the regulatory agency giving them the option of doing this.
Okay. So would it be safe, following Patty's lead, to assume that we've got some closure on this bucket, this domain? I think we do, and then therefore thank you. And I'd like to move on to the second one that's received a lot of discussion, not only this morning but in the last 2 or 3 meetings, the domain of encouraging patient-centered care and engagement. You'll see, actually, we have 10 rows here. So this is the most built out. And why don't I suggest that you look through those. And things you will see again, with one exception. There's row 7 on the second page, where we, there are 3 exceptions. Row 7, we are suggesting the regional level, and then rows 9 and 10 about patient education, where MHA has agreed to lead an effort on that.
We haven't agreed yet.
Oh, I'm sorry.
It's just on here.
It's on here. MHA has agreed to consider, pardon, doing this. That is designated at the local level. So comments are welcome on this domain.
Jack?
Yes.
So I have a lot of questions about this, and it goes back to the realm of possibility that David laid out for us in his initial presentation, embellished by Howard. And perhaps we could start the conversation by just getting some sense from the group as to this use of the term care plan. Because my understanding of when I use that term, I would suggest that it's something not doable. Meaning, this is not going to allow us to create a care plan that a care manager would use. David, you introduced the term care profile. Howard talked about the CCDA-like document, static, opportunity to view some new information, but that's not a care plan in the way I would think of the word. So I think we can start with some definitions.
So that was the language that I was going to comment on too. And I think if we start with something that sounds like leverage existing standards, identify gaps, and propose a potential future state for care plans, HRA, even the elements, even before we get to the technical, what goes in it, how do we do it, what are the elements, and is it we've talked through some options of CCDA plus a whiteboard that could be added to by multiple people. I mean, there's lots of technical possibilities, but to Patty's point, in our organization, not only do we have 9 electronic health records, we've got 4 quality management systems and a soon-to-be population health management system, all of which produce something called a care plan, none of which talk to one another.
Lori.
So I think my comment is probably similar to what I'm hearing, and it's to number 7, I guess. We've been talking a lot about care management and care planning from the top down, from the hospital system down. But there's an awful lot of this, at least in our world, that happens from the ground up. So what we're trying to do is care manage people so they don't end up in your facilities to begin with. And then also, of course, if they do, try to work out interventions so that they don't go back again. So I don't know. I am concerned about the duplicating an efficient and effective wheel simply because not everybody may know that that wheel exists out there. So I don't know how to work that into this document, but I guess part of my role in this table of really bright people is to continue to try to bring it down to the weed level, that there's a lot that's going on that this group may not know about, and how do we not forget about that and end up setting up systems that conflict or reproduce what's already happening.
Okay, I think I saw Ben's nameplate up.
Yeah,
This is new.
When I look at this, it does seem as though it might benefit from breaking this bucket up in a different way. And I'd even suggest the first item might actually be better up under 3 above. But it does seem like a bunch of different activities that, including some of the public engagement campaigns, that some additional rethinking about that and who you want to engage. I'm always skeptical of consumer outreach activities that are launched by stakeholders and identifying consumer groups that would participate in those as well. In the latter 2, 9 and 10, it strikes me as MedChi as well as MHA, but consumer groups as well need to be really flagged as playing key roles. and perhaps there's the way you do that is between the sort of public awareness activities and the how activities that seem to, for me, neatly fall into what this bucket is largely about. The technical activities might be better off broken up separately, and then the public engagement activities are a separate bucket.
Okay.
I would agree with that.
Okay. Howard, then Adrian.
Yeah, I really want to go back to the concept that this has got to be something that's really simple to start out with. It's not a care plan in the sense that anybody thinks about whatever their institution's care plan is. This is a standardized document. It's the thing that could carry the very basic but very, very valuable information from one place in the system to another. And I don't want to minimize the value of that, because I just have to remind you, we don't have that now. And that's really what we have to create. And if we fall down because we can't agree, because it's got to be something grand and glorious to start out with, it would be really sad to lose the ability to get started. This will grow, there's no doubt, and there's nothing that has been introduced in the digital age that didn't grow over time through iterations, through wiki processes, through whatever it takes, and will be able to be used to get de-identified data and garner great inferences in the future. But we really have to get out of the blocks now. I think we have to get to yes, and we're going to do something, and not get, as you said, not let perfect be the enemy of good. Thank you.
Adrian.
So
Thank you.
I'm glad that Howard got to go before I did, because I really want to agree. I think that, and I understand, I guess maybe I have the luxury of not ever been into the hospital, so I don't know what the discharge plans, the care plans look like, but I know that one of the biggest barriers to patient engagement is overcomplicating and having a lot of duplication. And so having something simple that people can use and understand, I think, is really going to be critical. And I guess I understand that, not all the systems talk to each other, and Hopkins care plan may be different than the University of Maryland care plan, but having some kind of document where patients can engage with their care managers is really going to be important. Otherwise, if they've got 12 or 15 different documents that they're expected to look at, it's just not going to happen.
Yeah, I'm not sure exactly what level of engagement any of this will change with regard to how we interact with patients. But if you think about a hospital, when it uses the term care plan, it is specifically for purposes of today of what that hospital is doing with that patient. So that care plan is focused on the admission, the discharge, now very much the post-acute readmission services, and there's what we're trying to do here, if I understand this correctly, similar to what we did when we first stood up CRIF, is create the opportunity to have health information exchange across a continuum of unknown proportion. Because we don't know where that patient's going to end up after the hospital, 60 days or 3 years. And so this static kind of need to at least have the opportunity for any provider, just like we do now with CRIF, to access some simple set of information. And so all these other care plans, that will be interesting to see how all that work evolves as each of us in our point of service or our system levels are, contemplating how to integrate that care experience for the patient. But I think we just got to remember that this is not, we can't boil the ocean. But I hope that everybody is on the same page with at least this initial opportunity. And I think Howard has articulated it. What's that care profile that one would have to sit down to design that you would want a system to make available through the highway, which is going to, a care manager at a health plan or a care manager at an acute care unit may or may not find that particular document useful, but it's like, patient saying, here's my electronic medical record, stop asking me all these stupid questions, it's all right here. Well,
Right.
That's the profile that I think we're looking for.
That is different than an individualized care plan that says you have this episode and we need to do this to get you well.
Right.
Okay, thank you. Ernest.
And it's also different than a longitudinal care plan that is to be used for case management over a longer period of time.
Right. So if somebody's enrolled in a,
right, and that can be addressed in a different way, even if we're doing those in PDF and sending them along to people who need them.
That's right. If there is one, then it can be made available. I think David referenced that. I think that's in here too. Yeah.
This is a very interesting discussion, and I really appreciate it because this is what we're struggling with in Prince George's County, because there's a handshake between the hospital and our patient-centered medical home, a handshake between and their case man, and then it's more than just a handshake between the medical plan. It's a handshake between case management plans and other things. And then there's a handshake between our behavioral health and our patient-centered medical home, and then our other services in the county, and all of that sort of coming down to the point of care where our community health worker is totally confused. So, so what we're, it's everybody shaking. But there is a body that we're sort of that's created out there called this care coordination team, and they need some essential information in order to keep that patient out of the hospital. So we're looking at how do we keep the patient out of the hospital, not only prevent medically related events, or medication-related events, but these other events. So it's more. So there is a component, and the profile I like, Patty. I like that term too. That's a good term. There is some basic elements of things that a care coordination team needs in order to affect all these handshakes. So at the point of care, whatever system that you created with your care coordination team can be effective, and we can measure that. So I think what Howard said was correct. We had to create it. I mean, some of it's there, little pieces of it are out there in literature and stuff, but it's really not there. So Maryland is going to be tasked with either creating it or we won't get it done. So it's going to be a priority. I mean, in terms of how this whole thing happens. And we have to do it from the patient's needs up, I think, and not from the institutional needs down.
Yeah.
May I try another chairman's mark? And I'm going to push us, so please push back. If I'm listening correctly in this category, item number 1 follows item number 3 in the previous category. That is, we said we first need a process to understand consent. But we have to go through that before we can figure out what a standardized consent form may look like. I'm then hearing that items 2, 3, 4, 5, I'm trying to figure out if it's 6 or not. Mark has put a suggestion on the table that, again, we haven't identified crisply the initial activity, and that is to leverage existing standards, identify gaps, and propose future standards for the creation of care profiles. If that becomes the first step, we do that process, and then it's in the hopes that we do that well and successfully that then we get to, at some time before we all have gray hair, 2, 3, 4, 5. And then that leaves us with, I think, 2 ideas in this second bucket. The first is the one that Mark has put on the table. Let's do that process to create the undergirdings of a care profile. And the second is a combination of 8 and 9, where there's a second sort of big idea in this, and that's really about education and public awareness. Is that fair, that we can pull this second group down into really 2 distinct ideas? One, again, being this leveraging existing standards, identifying gaps, and propose future standards for the creation of care profiles. And the second, maybe some more conversation around this issue of a public awareness effort. Push back, though.
Yeah. Howard and I exchanged glances
I do
there.
too. My son said, "Nice highlights, Mom." Yeah, well, not really.
So can I make sure I understood you? So I agree that whatever you said, I put my thumbs up on. So that was great. The result of that is that we would have resourced an effort to design a care plan.
Or a care program.
Excuse me.
Oh.
Excuse me.
Right.
Care profile. That's right. Then I would. So that's kind of one set of work, and then I would suggest, and then immediately after that, we do need to get to 5, which is how do you make that visible?
Correct, and my thought is that what we are suggesting, we all jumped, I think, at our last meeting to outcomes.
Yeah.
Here's what we want. We want, standardized elements. We want, a standardized risk assessment, but we have to manage the process to actually figure to build the track first. But I think you're right. My thinking is 2, 3, 4, and 5. All of it falls out of that process, but the process is a little bit broader to say how can we create that care profile.
Well, I was just simply saying that I don't know. I think 2, 3, and 4 definitely falls out of that process, right? Yeah, create and expose. That's all. I just think we need 5 in 1. Yeah, because there's some technology that has to be reviewed.
Okay, 2 through 4, maybe not 5.
I think we just added 5 if it's create and expose.
Okay.
Create and expose a care profile, or create and...
It needs to be done with a mind for what's possible.
Exactly.
Yeah.
That's my point.
Yeah.
That's all.
Right.
I had a question. Is there room in this for an assessment of whether it's working or being used or functional?
Well, I think.
Yeah.
I mean, I think the question.
In a way, that's part of Joanne's. That's a different reflection on Joanne's point. If you build it, you got to use it. Is it working? Is it helping people?
Yeah.
Yeah.
Care plan is a dynamic document, I would think. Things change, and depending what elements are on there, particularly if meds are on there, my gosh, they change daily. So who owns the care plan? Who can alter it?
Let's use the term care profile.
Sorry.
Yeah.
So, but I'm not familiar with how that differs. I don't know what elements are on a care profile versus a care plan, but I do know that people change, and who's seeing them change.
I think all that has to be thought about in the design of it.
Right.
I mean, I think
The care profile needs to be a public utility. It needs to be something that everyone has access to. The care plan seems to be something that would be owned by, the design of it would be owned by whatever entity is doing it, whether it be Maryland or Hopkins or a private physician, and the patient, who is their medical record, obviously. But the plan, we need to make the easy, simple thing that we're going to start with baby steps, that, as according to Dr. Haft and David, I think they're both right, should be something that we all kind of get agreement on, and then ideally, it would be something that we could send out to anybody, and they could, but that should be something that's a public good, a public utility, because if one of my docs on the Eastern Shore sees somebody in their private office, and then they end up on the University of Maryland, that standard care plan that they get through CHRIS should be the same, so they see that same basic information. And then whatever they do in their offices is kind of different. And then that way, we're not creating all those problems that we have when we have the discussion about the investments you guys have already made. You know, those things are still good and still valuable, but we're providing value through CHRIS that's easy that everybody can use. And that's kind of in my head how I see it working.
Man, thank you.
I would encourage us to really pause on this care profile or care plan. I agree that, you know, as Dr. Carter said, we don't have good care plans now in general. Sometimes in mental health arenas, we actually have good care plans, and sometimes in disability arenas, we have really good care plans. But the shift from acute care medicine to chronic care, it seems, is most symbolized by the existence of a longitudinal care plan. And we could certainly skinny it down or enrich it with detail, but let me just read off the key elements that CMS put in the CCM care plans suggestion, and see if anybody would actually want any of these dropped out. The first is the problem list, expected outcome, and prognosis, and the treatment goals. Hard to do without. The planned interventions, the community and social services, the plan for care coordination, medication management, a reflection of just how fouled up that is. Gets special notice. It's really part of planned interventions. Responsible individual for each intervention, and requirement for review or revision. I mean, you can maybe try to take something out of that, but I think you would end up with, you know, an animal without a limb. You know, you can crystallize or summarize the content of some so that there, there's an existing document that maybe has 3 paragraphs and you put it in a sentence, but it seems hard to actually get rid of any piece of those and claim that you're doing chronic care management. So just to think about whether the care profile is something that is really discernibly skinnied down from this by dropping out whole pieces, or whether you mean it to be more of a summary, and somewhere else there's a lot of documentation about what the allergy was like, but the daggone allergy is here. That's the sort of thing I think we have to be careful of. I don't know what a care profile is separate from a longitudinal care plan. And without a longitudinal care plan, we aren't going to be able to manage these folks well.
And if I may jump in, because I think this one is ripe, to your point, Joanne, for significant additional work that we're not going to get done here around this table. I am sensitized to the presentation that David made earlier, and it was on page 9 of his slides, where it's perhaps less the length of the document than it is whether it's a living document or not. And I think David explained that storing and viewing the information is going to be a whole lot easier than editing the information. And David, I'm wondering if you want to comment, because I think that the issue that needs to come around another table and really get worked through, it's one thing to take what may be a point-in-time care plan and make that available. The challenge is in understanding, as other people are adding and treating and caring for an individual, who gets to change it? Who gets to edit it? How does that get back into David's world of cyberspace?
You said it very, very well already, Carmela, that we can make a very comprehensive care plan somewhere, and it's easy enough to deliver that for someone to view. But when we have information that gets used and updated by lots of folks, the more comprehensive, the harder and harder and harder. When I hear us talk about a simple care profile, and Dr. Schenkel described what he might want in an emergency room, and Dr. Pat Zapp, when she was here, I get excited about that. And then the more elements that we talk about adding in, I just feel it in my stomach. That is going to be a real bear. So, yeah, something simple that can be edited and updated. We can present full, comprehensive care plans if they're created somewhere. It's the editing and interoperability that gets harder.
Okay, could I? Oh, yeah.
I think this is really important to get clarity on. I do not support today this group prioritizing the creation of a longitudinal care plan, because I don't know. It doesn't make sense that we're ready for that from a public perspective. It has to happen. I understand that. So I think I support the iterative approach, which is let's identify a care profile consistent with standardization, doable and viewable, and then to Steve's point, figure out a process by which people actually start using them. How will that happen? We need connectivity, and so there's just a little bit of work there as we kind of evolve.
So what I was going to suggest.
But Patty, would you support having a standard process to share longitudinal care plans that exist? I mean,
yep. So to the
and
extent
making it known that they exist, so that our highest need patients who have longitudinal care plans, that we have a way to identify them and to share the
and we
plans
should be
that
defining
exist.
that process in some, because that's where you can, ping someone, say this patient who just opened your ED has a care plan. Go look for it.
Okay, can I suggest, following up on an idea Ben had, which I think was a good reorganizational item, that we take number 1 under encourage patient-centered care and really understand that it's subsumed, if I understood Ben correctly, and I think he's right, under 3 above in the build secure. We've already got number 3 says develop procedures to secure patient consent, so there's no reason to repeat it. And then take the items that Patty was just ticking off, which are an improved way of organizing 2, 3, 4, and 5, and draw a line under 5 because then we change the subject. So those to review, if I captured Patty thinking right, identify, care profile, share, make it shareable, make it, as she called it, doable and viewable. I like that term. And make sure they're used, so there has to be connectivity. Is that something that that cluster that we have an agreement on? I think we do. Thumbs up, nodding, good. Okay. That means that we've moved number 1, Madam Chair, and we have 2, 3, and 4, and 5 kind of reconceptualized. So, in the interest of time, thank you, let's look at I'm wondering if 6 is in there. Yeah, 6 is in there. So let's draw a line under 6 and then talk about 7 and 8, which really get into a different kind of thing that involves collaboration, education. Does that make sense?
And I wonder, Adrian, because you raised the issue of number 7, and something I know Donna and I have talked about, and that is how do we avoid duplication of resource. In my own head, I'm struggling whether 7 is its own item or whether it falls generally into this public education, public awareness bucket. But Adrian, I'm wondering, if we go down to the next bucket, I'm sorry that I'm now making brain connections, under encourage collaboration, and look at number, it's the second number 1 over to the far right, creating a web-based inventory of community services available in the state. One of the things that I have heard as I've worked with our hospital members across the state is how do we understand what's already out there, already in the community, and create the partnerships and the relationships as opposed to standing up a new resource. I'm wondering if that sort of solution really ties and connects, and I don't know who had offered number 7 before we took these off the list of that everybody had offered up. But can we make that connection? Does number 7 in a sense move down to the next bucket?
Like this?
Yes,
okay.
Exactly.
Move down to the first point under encourage collaboration.
Where the way we're wrestling with that is raising awareness about community facilities community services that already exist.
I'm seeing Lori's head now, but I think she's agreed.
I think that's a good idea. I mean, 7 seems almost like a design principle that applies to virtually everything. Avoid duplication. I don't know where it fits best, but I think pushing it down where you eliminate that is through collaboration.
Okay. Okay.
Yeah, I agree with Ben. I think it is more of a design principle. So we want to avoid duplication in, we can move it down under part 1, that's fine, but also duplication in terms of do we need 6 long-term longitudinal care plans for someone's chronic illness. So I think it kind of, we need to consider that and as we move forward in the discussion of other things as well.
Okay, thank you, Adrian.
And I would just say, I think there already is a website. So maybe DHMH, I think already, I don't know if it's DHMH, but there is already a website. We may want to, I don't know how well resourced this is or how updated it is, but it may be something we can do there as opposed to standing up something new.
By the way, anybody on the phone that hasn't had a chance to chime in? What's the website? Okay. Kim, is anybody on?
Yeah, there's a lot of people.
Okay, we have some colleagues on the phone. Would any of you like to offer a suggestion? This would be a good time. Okay. Mark.
Just a quick comment, teeing off of what Adrian just said. The connection the other way would probably also be useful. So all the hospital providers have care coordination programs. A lot of physician providers have care coordination programs. And the payers have care coordination programs. And if we could, in one place, identify the contact information that way as well, so that we really have a single place where care coordination, resource, and contact information would be, I think, would be useful.
Yeah, kind of a repository of those different ones. That's helpful. I'm thinking that number 10 we haven't really addressed, this is sort of the last item under encourage patient-centered care, and then maybe we can move on to collaboration, which is really different. We've got about 20 minutes. Well, yes, but I was thinking that we would combine that with something, but I'm wondering if yes, we do have to do it. I'm wondering if we've already addressed it. No.
And if I may, it goes to
Yes.
Jean's earlier comment.
Okay.
As I think about 8 and 9, this is really what do we see as our responsibility to suggest if we think it's at the statewide level or is it at the local level? And Jean, to your point, and Lenny's in the back, to what extent is this work that we are facilitating through physicians' offices, hospitals, and through the consumer work group and some of the community forums that are ongoing, or is there some other aspect to this that may be statewide? Are we I'm making it up. Are we calling for statewide public service announcements? So what are we looking for here? And I would agree. I think there are many, many people who could be involved. As I look at the lonely MHA letters that are sort of sitting there with a couple of these, I think there are many people who could be involved. Can we just take maybe a few minutes to see what this group thinks, and where is this on the priority list for us?
I like joining 8 and 9. We may want X's in more than one column. Comments on that? Adrian and then Lori.
So I think exactly what you were just pointing out about having X's in more than one column. So maybe it's having some activities that are statewide. Maybe it is a public service announcement. Maybe it's the development of some of the educational materials. If we're thinking about these, a simple care profile, then we need to. There's no reason that the regionals should all be creating materials to educate someone on what their care profile looks like or why care coordination is important. But then the actual on-the-ground education of that individual patient is going to happen more at a regional level. So I think maybe a more kind of like an awareness campaign and the developing of the materials makes more sense, or the messaging makes more sense at the statewide level, but then the actual on-the-ground implementation of that education and engagement is going to happen regional or locally. I would say locally, not even regional.
And Adrian, may I ask, again, just pushing us to clarity, so who should be responsible for that? Since part of what we're trying to flesh out around this table is who's going to take the lead and how we're going to pay for it. Do you have any thoughts?
Who should pay for it?
No, who should take the lead? Because what we tried to do to Jean's, I think, last meeting comment in this implementation strategy, all right, if we leave this table today or we're in one more meeting, who do we want to tag with this? Is it important enough to tag somebody to do it? And who's the somebody or who's the coalition?
So I think that the HSCRC Consumer Engagement Work Group is a good place to start. I don't know if you want them to own it or if that makes the HSCRC the owners of it, but I mean that group is already established and has quite a few people on it who are doing some of this work already. But I guess I haven't really thought about whether it should be MHA or HSCRC or who should actually own that group's work. But I think if they're already established, there's no reason at least not to start there.
I have Jean, Lori, and Patty.
So I would say I'm more than willing to serve on like a subcommittee to work on this issue if you want, and I think it's something that's important. And engagement is different when you look at different sectors. Consumer engagement, we want to talk to Vinny and Laney and those kind of people. For physicians, I think you cannot underestimate the changes to their workflow and the support physicians and other healthcare providers, practitioners are going to need as they change and start using these things. They're just not set up for that, and that's going to be important, and that's one part of engagement. But then the second thing that we found, we've been working with HCAM on doing engagement around the insurance exchange, and we've been getting physicians' offices, unfortunately only in a small region of the state because of the way the state did the exchange. But we have found that physicians actually, when we go out and talk to them about engaging patients, about how to sign up for the insurance exchange, it actually works, and they listen. And physicians are in a very good position to do that. So the other part of engaging physicians is to make them the agents of talking to these patients and saying, hey, not just sending them out, saying this is the care plan that we've created and you need to actually pay attention to this, it's important, and here's why. And if the physician takes another few seconds to do that, that could be valuable. So I think we're part of the engagement piece. And then I think there's other parts as well. So maybe the way we do this is we pick a couple of us to kind of come up with an engagement plan that makes sense. But I can't, I mean, I couldn't do it myself. I think I'm part of it. And then there are other people here who are part of it. So that's kind of how I would see us moving forward with this. And I think it's important.
Well, thank you for volunteering. It's good. Again, I like the breakdown of consumer, physicians, hospital. I'm gonna have Lori, Patty, and then Ernest. I'm trying to do this in the right order. You're next.
Engagement in education is sort of like what they said about voting. Do it early and often. And so the more at every level that we can try this, it's going to be helpful. For the people that we serve, the real engagement is going to happen at our level. It's going to happen at the community organizations. It's the people they see every day. It's the people they trust. And maybe at some level we can start to connect when people admit or go to the ED that we can see if these individuals have given consent for this care management service and connect the dots with who has given it and who has not. Where does it make sense to engage? Because there's some people that we still have difficulty engaging that are going to show up in your ED. So then where does it make sense to try to get that person to sign on the dotted line and constantly have that running tab of who we need to outreach to?
Thank you. Patty.
So I think there's a point that we've missed in the process and will inform the answer to the question around engagement. And that is we start with the premise that we have a problem, i.e. of a waiver that's requiring us to reduce costs for Medicare patients. And that one solution to that problem is to identify the high-cost Medicare beneficiaries, which is what we did in bucket 1. And then we moved into, which I advocated for, what's that doable process, leveraging CRISP to create some type of information. I think what we didn't ask ourselves or clarify is that's for everyone. We're not saying we're going to create a care profile for 40,000 patients. But I think so. We might want to think through: do we need a separate bucket to say, well, what are we going to do with the 40,000 patients? But the education piece is then also relevant. Are we really focusing on how we're going to educate these?
If we could ask everybody on the line to please mute your phone, and hopefully we can deal with the echo before we have to do something more drastic.
My point is that we have to understand who we want to be educating initially. And if there's a strategy to educate 40,000 beneficiaries, that's one thing. If there's a strategy to actually begin a public conversation around patient engagement, then the education is much broader, and the constituents, are obviously different.
I want to say it's not just 40,000. If we're going to tackle the CCMC, it's more likely. It's 60% of the Medicare population has 2 or more chronic conditions, so they actually qualify to participate in the program. So it's a large chunk of Medicare patients. If you guess the number who we could successfully enroll, it might be something, right now we've picked a number and we're saying 280,000. So that's a lot of people. So it's not just 40,000 if we're actually going to align with the primary care provider's interest right now with the support of Medicare money. And so I think that, I know that's part of the reason why we are drawing up and saying we need a care profile, which is different than a longitudinal care plan, because we need to respond quickly to this the opportunity to align with primary care, which has been from the advisory work group forward has been said over and over and over. We need to be able to align with physicians, and in particular primary care. The federal government has come behind us and said, hey, we could pay over $100 million in Maryland to help that process along. And so we're saying, great, here's what we have to do to take advantage of that, and we'll have to go back and price it out. But that's really the conversation I think that we're having, that we need the 40,000, and we need to respond to this tremendous opportunity to create alignment between primary care and community-based providers, not just primary care, but community-based providers and the hospital objective. So we have a great opportunity.
So let me see if I captured your thinking, Patty, because I heard you say, I think, and it seemed right to me, that we missed a step in there, that there's a 1A before B or something. And I think what you were saying, but correct me if I'm wrong, is that we said, let's go get the data, use what we have, get the Medicare data, identify the high needs patients, build them health risk assessments, and build them a care plan. Take that all down, and maybe that's 40,000, 80,000, whatever it is, but complete that thought of making sure that we actually use that data to improve their care. Then the next kind of task is leverage, Chris. This is for everyone. The profile broader than the 40,000. Am I capturing your thinking?
Well, I didn't. You captured it to some degree. I don't know what the right step is once we identify the 40,000.
Right.
I don't know that I'd be ready to say the right step is for us to figure out how we get all of them on a care plan. I just don't know.
Yes.
But I think it has to be part of a process to answer.
Yes.
That's what we're trying to do.
We're not just collecting the data to collect
yeah,
it and
exactly.
store it. We want to use it.
This other bucket is broader,
yeah.
And then the educational will end up being broader.
Yes. Right. Okay. I've got it. Point well taken. I'm thinking, since we only have 10 minutes, 12. No, I'm sorry. I missed. I'm multitasking at 4 levels.
That's okay. I'll be really brief.
No, you don't have to be.
Okay. Well, the point on patient engagement, and I hate to make this point, but I have to make this point because this is my job. The public health department, public health is the broker between the hospital systems, the payers, but the public is where our bread and butter is. Our goal is to improve the health care of the public. So when you get to patient engagement, you can't leave out the public health departments that are all across the state. They need to be coordinated in this effort. And public health is transforming, and I know you all don't think about it this way, but we're actually integrating with primary care, with the healthcare system. So when you think about patient engagement, this actually happened with the ACA. When you leave out the public health department, you find out you didn't get as many of those patients that you thought you were going to get signed up for Medicaid from who were uninsured, because that's who the public health department deals with. And then when the public health department becomes more engaged, the numbers go up. Even though the doctors are the center of attention, believe it or not, public health actually works to engage patients in the healthcare system. So having said that, and when we talk about ownership, don't leave the public health department out. I believe it has to be a partnership between multiple partners. But the public health department actually takes the lead in trying to figure out how do you get these care coordination systems and all these plans, et cetera, that work for this targeted population. So anyway, that's just my 2 cents.
Oh, you're absolutely right. And we had a presentation a little before, I think you came on the panel from San Diego, where the public health department there and the leader came in. They are a convener, not just, you're right, it's not just that they bring in the most vulnerable patients that they are serving, but that they convene the players, and they are doing that in some of the SIM models, Illinois, Michigan.
Right. Well, that's the role. That's the new role of public health. You know, we have to worry about diseases and but the new role of public health is to be this convener and to get data out of it and see whether or not what you just proposed actually works at that local level. So that's what. So in terms of patient engagement, I think the public health departments have to play a large role.
And if I could jump in, this may be one where we ask DHMH to take the lead with the public health departments and organize the rest of us around that. I think you make a very good point, which is this is your bread and butter.
Exactly.
Thank you. That's good. I'm really glad I didn't miss your sign, Ben. Now, you said Ben, your sign was up.
Oh, sorry. I'll yield the balance to my
side. All right, Joanne.
Very quick point for those who are working on the education. One of the shifts, again, in shifting to a chronic disease as the main target is a shift toward patient self-activation for self-care. And so the education model, the education language, implies that there's someone who knows a whole lot who's laying it on somebody who doesn't. And it's a very different model to set out to activate the patient to become their own manager. And that turns out to be a terribly effective piece of the intervention that Patty's been looking for. So we might want to label things not just as education, but also as activation for self-care.
Okay, good point. I'm going to bring this part to a closure. We only have 10 more minutes. I want to spend that on the collaboration. And I'm sensing from comments from Adrian, Lori, and Jean. I think Jean is stepping out right now, but no problem. I know he did. That putting together, synthesizing some of the comments I've heard, this is not something where you put an X in one column and not the other. That there are areas here for statewide activities, statewide campaigns, but there are also there's also an important role at the local level, and as Jean pointed out, there's the educating and getting committed the consumers, there's the physicians, there's the hospitals, and I think somebody also added community organizations. All those are vital cogs in the outreach at the local level and finding people where they are. So I think if you agree, we have closure on that, and I think we have closure on Patty's point about distinguishing between the effort that's going down one track to identify the highest needs patients, get information on them, risk assessment, ultimately leading to serving them with care plans, but we're not there yet. That may not be our job, but we know it has to be done, versus the more public-wide, patient-wide activity where Chris plays a vital role that's not limited to the highest needs people, similar to Donna's comment about the 60% that would have the broad. Do we have kind of general consensus about those items? Okay, I think we do. Again, by the way, you're going to see all this in writing. So, you know, I know some of you said, and I'm going to mention this later, but one of the things we at HMA are doing is starting to draft. We have drafted some preliminary chapters that feed back the conclusions we've reached at each meeting, and have shared some of those with HSCRC, and they're reviewing them. Those will move along to you at some point. Then as we finish this meeting, we'll be drafting. So we are going to be drafting on your behalf as a report to HSCRC from this working group. A report. It's not going to be 80 pages. It's going to be more like 25 pages with a good one-page, two-page executive summary. It's going to have recommendations. It's not going to be some big, thick academic tome, trust me. But it'll be your report to mark up. So you'll be getting that. So I only say that if we haven't exactly captured something, you're going to see this in writing and have a chance to get your red pens, track changes into it, and comment.
At great risk. May I attempt a third chairman's mark?
Yes.
This
you
bucket.
You have an unlimited number. I haven't capped you.
Thank you.
You're the chair.
Thank you. Under Encourage Collaboration, we've got 6 items, and they're all very important. As I reflected on this just yesterday, as I went back to think and prepare for this meeting, there is one on this list that stands out for me, and let me float this and see if others share it, and that is item number 2. As I look at the other items on this list, at least I am aware of places where we are working together, coming together within the state to make things happen. I am wondering if number 2 really deserves to be called out. It is a problem that we continue to hear many talking about. How do we create this integration of somatic and behavioral health, and probably one where there are very, very few answers. And wondering if this is another sort of single place that we could put some effort and resource to see if we might be able to build a better mousetrap.
Yes. Yes, no, absolutely, and I just wanted to mention that one of the, by the way, when I mentioned we're starting to write some chapters, we'll rewrite those and reiterate them as we go.
Why did the pain get worse?
What was that? I'm sorry. Well, I'm going to call on somebody in a second who has a question. So what I wanted to say is, in the process of putting together a chapter that says what are the exciting things going on now in Maryland that we could build on, a member of my team, not here today, Jessica Foster, has spoken to Adrian and Lori and got a ton of useful information on this very subject of what's going on at Mosaic, what's going on at HealthWave, other initiatives that we are going to feature as things that could be built upon. There are other areas as well. So I just want to say we're trying to capture that. You're absolutely right. It comes up over and over again. How do others feel about the third chairman's mark, chairperson's mark? Lori.
I absolutely agree. I think that it's such a focus. I hear it everywhere I go, on every meeting that involves hospitals, discharge planners, that they feel like they don't know what to do and how to get out of this conundrum. And meanwhile, we're sitting out there going, but we have all these neat things going on. Can you please utilize us? And so it's not just even knowing the kinds of best practices or things that are happening in the community, but how do we get the hospitals and the community organizations to talk and work together? You know, who is it that we talk with? What, you know, who can say, all right, I want to contract with you to do this, for instance? It's that elementary. We're at that level of non-discussion at this point, unfortunately. So I think that it deserves being singled out, because often, even though everybody says it's a problem, somehow behavioral health ends up getting the short end of the stick in terms of attention and finances. So I would totally agree. A lot of these other things, I wouldn't want to lose the ability to incorporate them if we pull that out. So the idea of gain sharing is very important to us. We have very little ability to get any part of savings and reinvest it in our services. It just doesn't exist, and it could be very important to us. I mean, just the notion of looking at ACOs is important, but again, the chronic health home. Chronic health home is doing some really important things. Unfortunately, we can't take Medicare onlys because of the way the Fed, created it, but we do take duals, and they have a lot of disability, chronic illness. So there's a lot to be learned from, and I think we need some oomph behind it to start pushing some real effort. Because at this point in time, what we're seeing mostly is people get discharged, and they got a name of a clinic, and about 80% of them never make that first call or show up for that first appointment. So we're losing them right off the bat.
Thank you. And before I call on Adrian, our colleague Marla, who's a member of this work group, has been waiting patiently, and I think we have her hooked up, and she would like to make a comment. So Marla, if we still have you, would you please join in, and I apologize for the delay.
Maybe on mute.
Could you be on mute, perhaps, Marla? Oh. All right. Maybe somebody could email her, and maybe she'll want to jump back on. I also just wanted to ask a question, because somebody, on behalf of somebody listening in on the webinar, in fact, Shanna Koss, has asked, to what extent are you intending the profile to be vetted and shaped by patients as well as providers? And so I think I'm seeing some heads nod. Shanna, thank you for that question. Everyone here seems to agree with that. Yes, they need to be vetted by patients. Absolutely critical, and not just the sign here, but to have patients have some input and consumer groups have some input. So I'm getting a lot of heads nodding, and I'm going to say we hear you. Thank you for that comment. And if somebody could email Marla Oros and see if she could come back on and apologize, and when she comes back on to try to apologies for that. Okay, Joanne, I think the question on the table is highlighting behavioral and somatic health integration.
Yeah, I would just encourage us to also include as a high priority the next one about long-term post-acute care. because the gamble on the money in Medicare is, a major driving force, it has come to be that almost a quarter of all Medicare funding is in the 90 days after hospitalization. And it's a largely unregulated and unexamined area. And private contractors are jumping into that space and extracting 50% of that money. So it's 12% of Medicare that is going out of the system, from that kind of contracting. Now, some of that is, a lot of that is quite realistic. That we've kind of gotten into sloppy practices. So in order to win on the Medicare gamble, it seems that we really have to pay attention to the 2 or 3 months after hospitalization, or we don't really have a chance of winning.
Okay, I'd like to then ask, I'm going to do Ben next and Mark, but also to comment on these two, and we'll, at Joanne's suggestion, look at both 2 and 3, and that may be all we can accomplish for today. To also look at where the X's are and tell us if you feel those are appropriate in those two. Ben.
Yeah, just very quickly, I echo what was just said. Earlier this week, we showcased some of our HIE telehealth projects. Thanks a lot. I should know that. Telehealth projects, three collaborative projects between nursing homes and 3 hospitals in the state. And the feedback was this has a lot of benefit, but from the standpoint of the long-term care facilities, we really don't know how we can sustain it. It may yield cost savings to hospitals, but if this, I guess I like the bet better than a gamble. If this big bet's going to succeed, we have to consider what's in it for comprehensive care facilities as well. So I think 2 and 3 make good sense.
Okay, I think I saw Mark and then, oh no, Adrian, you were waiting before I cut into your time to go to the phones. So you're next and then Mark.
Very quickly, I want to just agree with everything Lori said about somatic and behavioral health, but then also I think, and this kind of maybe goes back a little bit to the patient consent, and I will put our behavioral health providers on the spot. I think they need to play a role in educating themselves about what actually is protected in terms of what information can be shared, because there is definitely a misperception. I mean, substance use disorder records have a very, Part 2 is very different than what can be shared for mental health records. Mental health records are not as protected under Maryland statute as the mental health providers believe that they are. And so there needs to be some education happening that information can be shared without very explicit consent. So I would say that needs to be added there about how the sharing of the information from the behavioral health providers as well.
So that's a perfect segue, so if there were unintended consequences about HIPAA, there are definitely unintended consequences about the Maryland law restricting psychiatric notes and substance abuse notes. I will tell you, though, technically, it's really challenging to tease out this information is acceptable to send and this information is not. So unless we are covered somehow under Maryland regulations, we, the providers, are going to have to take the more conservative view and not share the information.
Mark, it's federal regs as well that are limiting.
There's a movement to look at those, so I'm hoping people are commenting. SAMHSA's looking at the Part 2 and seeing whether or not that is too restrictive. So hopefully folks around the table are commenting with their concerns.
So I'm in favor of the separating out behavioral health and making those extra comments. With regard to long-term care, the one group we didn't really hear testimony from is acute rehab, right? I think when we look at our most expensive patients, many of them either went through the acute rehab process or should have but didn't get into the acute rehab process. And so I want to make sure that we are reflective of that constituency as well.
Okay, thank you. Fine. Oh, Patty.
I would only make the point that whatever we prioritize in this domain, that we put this within the context of what we believe this group's current work is and or future work is, because we are now in a broader arena.
Yeah, that's a good point. Let me catch.
The ocean again.
Yeah.
But it may be the right thing to do because what you want is to leverage the momentum of the work that you're.
Right. Thank you. I'm going to make a suggestion, see if you're with me, and then we're going to wrap up this section. I'm going to suggest that number 5 is too big to tackle today, that is gain sharing and P4P. It seems like a whole new subject. Certainly, I don't want to give it scant attention. But it seems to me that, and correct me if I'm wrong, on number 6, and then we can close out on this and move to the final discussion of next steps, that we probably do have your consent and interest to take advantage of the CCM payments. This has come up at several meetings.
Just a clarifying question. Are duals eligible for that payment? They are. Thank you.
Yes. Okay. Good. I think that's about as much, Madam Chair, on the, I don't want to do some of these things in 2 minutes or 1 minute. We got about as far as we can, so with your permission, I'm going to segue to the...
How we are going to get there.
How we are going to get there, and next steps. And maybe we should just start with first bullet. Do we need an additional meeting? Should it be done in person? Is it a conference call? Would you rather see written materials sent to you in comment, or do we need one more meeting? Comments. Obviously, we haven't quite worked our way through all of this, and we also haven't done the budget part, which, as I said, my colleagues are working on, Deb and Art and Greg. So there's that. So there's a good bit that we haven't come to closure on. Comments welcome. Howard.
Can we wait to see what the draft looks like in the budget and then decide whether we need another meeting?
Let me jump in. I feel pretty strongly that we haven't made any decisions yet. Today we started this process of working through, I hear what you're saying about meetings, but I think at some point we need this group to look at some set of documents, this chart again and a draft, and say okie dokie. Whether we say okie dokie via email or okie dokie via phone, but I have a sense there is some convening exercise that probably needs to happen. At least from my perspective, we're not finished yet.
Yeah. I mean, I think we achieved consensus today on a lot of points, but we have to then capture that with some reorganizing and making sure we captured in writing, and you need to say, yes, you got that, or you didn't quite get it. So that is also true. And any other thoughts about the point that Howard has raised, or how you see this group? How do we wrap this thing up in the next few weeks in a way that you'd feel good about and would be ready to have a report go to Donna and the commissioners saying this is our best advice?
Well, I would encourage us to schedule another meeting and really do what we can to ensure that all of the work group members are available, and either by phone or present, so that you can feel comfortable that you've achieved the goal, which is a consensus of a pretty good representation of the industry.
Okay. Any comments on that? Does anyone have a different view? I'm not sensing that you do. So what I'm hearing is another meeting, but allow enough time. It wouldn't be next week. Allow enough time for us to capture everything we've heard. Allow enough time to finish the budget work, which is well along, but needs to be vetted, so to speak, and reviewed and so forth. And get everything that's supposed to be drafted, and then pull the group together and say, this is what we think you've come up with. Your okie dokie comes in there, or you need to, but at that point we wouldn't be raising huge issues that take us back 4 meetings.
Put into the time frame the opportunity for us to provide written comments, so that when you present that second document, you might feel as if it's inclusive of the comments of the group, and then we can fly. Which means that maybe you can pick a date for a meeting that's far enough out that people can actually get here.
Yes.
Put it on their books.
Yes, I think that's right, and I think I'm hearing, correct me if I'm wrong, that in addition to finalizing the grid, which we're moving along on, you'd like to have some chapters or some written material, a draft report sent your way, your attempt, your ability to mark it up, send it back, we incorporate your suggestions, and that's in front of you, right? That sounds like a plan to me.
Yep. And I think that next meeting is really just, if you will, a meeting of us. It's not external. We're sort of pencils down on the external presentations just to make certain we're getting to a final product that this group is comfortable saying represents the conversation.
All right.
And just from a budgetary standpoint, I want to divide the budget into two pieces. One is the first piece being moving forward with BRFA this year, and I think there's already been consensus that we need to move forward on a number of things that will exceed the amount of funds that are available. And so the HSCRC staff wants to take forward a draft recommendation, which we have to send out next week to our commissioners to begin the process to put that money into hospital rates so that it can be collected by June 30.
Sorry, I'll jump in. I don't think we can do that. I don't think this group hasn't yet seen that budget in front. I don't mean to jam you either, but how can we possibly do that if we haven't seen the budget, if we haven't sorted through that? Can we do that electronically with the commission after this group has seen the budget information?
No, we have a comment period, so we have a 60-day process, so we have to get something into the commission meeting, and then there's a 30-day comment period, and then we approve it. So we can change the recommendation in the middle of the process, so to get it to a final process. But just in terms of timing and moving things down the road to be able to put money in rates and collect it, we have to start the clock ticking now in order to get that done.
So may I ask Donna, I'm very uncomfortable with this. May I ask, what else could we do within the next week? If your team or Jack's team is working to putting the budget together for documents that need to be shared next week, can that information be shared with this group? Where I'm out of step now. I don't know how we put something in front of the commission that this group hasn't seen.
Well, my impression...
I guess this group has seen and contributed to a number of things. I'm not suggesting that we are going to put a line item budget on each of these 43 line items. It's to say we have worked through a process and developed preliminary recommendations that will require the deployment of the BRFA funds and to move that process forward at the $15 million level, not at the line item detail. The line item detail will take a longer period of time to sort out.
Yes, and the budget that we're preparing, the only thing I can say is not just how to use the $15 million worth of money. The exercise my colleagues are going through is, given everything we want to do, how much would that cost? Okay, which is a lot more than $15 million. And so the group has before it some idea, as we say, you should invest in this and invest in that, that this is what we think it comes to in terms of funding, because we think that's a responsible way if you're going to put forth recommendations. That's, you know what I'm saying? It's a different kind of exercise than saying it's exactly what you do with the BRFA money. Oh, I'm sorry, Steve.
So if I may clarify for the commission meeting, yes. So what we will be seeking at our next commission meeting will be broad authority to increase rates for the general purpose of what you all are talking about. As Donna said, not on a line item basis. That would become final in our April 15th meeting, with the hope that we would actually make rate adjustments on May 1st. So we should have some more intel. I assume if the meeting can be formulated between now and May 1st, we actually could have a little more intel in what the dollar amount may be in total. We don't necessarily need to know the purposes. We just need to generate the revenue in May and June in those 2 months, and so that it could be used for wherever it goes. That you
it doesn't have to be dispersed in May and June, but it has to be collected.
Yeah. Right. Yes.
Are all we saying is that you want us to be okay with, recommending that we spend $15 million on care coordination activities? That's comfort level.
And let me just mention one sensitivity, which is you've just heard, all of this $15 million comes out of hospital rates. This conversation has been a very broad conversation, and I think it would be very helpful, especially if hospital rates are going to be used as the mechanism to pay for this, that there is some broader context of other funding sources, sustainability. Here's where the challenge comes in. I think you will see Maryland's hospitals supportive of use of this, but it would be better if we could really paint a fuller picture. So I hear the need to ask the Commission for permission, but I'm just a little concerned that we haven't kind of seen that full picture painted yet.
Yeah, and you will.
I'm not as familiar with the process, BRFA process as others. What is the process by which you get approval or comfort level that the hospitals will agree to using the BRFA for this?
If the Commission puts the money in rates, then we create an assessment to collect the money and disperse it back out for the purposes outlined.
But is there a process?
Yeah, so it's similar to the same process that we use for funding CRISP, to say, here's we're putting this amount.
Does the MHA opine on whether or not it agrees to that? I just don't know.
The MHA comments on whether it's an agreement if it chooses to, and then the Commission takes that into account when it votes on whether to approve the plan.
And if I may, I think in an attempt to speak on behalf of Maryland's hospitals, these are critical activities. This rate increase comes at a time when there are many other issues on the table, including Medicaid cuts. And we're now doing this in the context of a global budget, which is just why I think it is incumbent on us to make certain that this group agrees that this is the good, best use of a pot of money that's out there and available, because rates are being proposed to be increased and decreased for other purposes as well.
And just if I may, being someone who is employed by a health system, I don't know that I would feel comfortable being representing whether or not that John Hopkins Health System thinks it's a good use of BRFA. I mean, there's just other conversations with other people.
And I think that the challenge that this timing gives us, it would be helpful if this is going to be funded through rates to be able to have a conversation with the hospital field about that amount and what that is, which is difficult to do unless we have the budget pieces done. Here's where the timing is very challenging.
Yeah, but it sounds like from what was described, we could start that based on the timing.
Yeah, I think, thank you, Steve, for giving us a clarification on the time. From what I'm hearing, we need enough time before this group meets again to have all the homework and material sent to them and reviewed, but not so much time that we miss a train that's leaving the station. That seems doable to me, given what you said, looking at my, like, getting this wrapped up in about a month, as opposed to 2 or 3 months. No, that'd be too late. But less than a month, we probably couldn't do it justice. Does that seem right to people? So that's what we have in mind. I want to end the meeting by, as I always do, by we have some folks out there that have been sitting here listening to us for a couple hours. If you have any questions or comments, this is the time. Yes, sir.
You don't mind if I sit here?
No, please.
My name is Jim McGee, and I administer the benefit plan for the Metro System bus and subway operators. And as a health plan and as a covered entity, we've been struggling with issues of care coordination for a very long time. which is why I've been so anxious to watch and observe what you've been doing here. I just want to make one small observation. I'd like the opportunity to maybe talk at greater length at some other time. But I get the sense from listening to the conversation, especially today, that all of you are convinced that you are engaged in some sort of care coordination activity. What I get from my perspective is a total lack of care coordination. And not only that, care planning at multiple points that is in contradiction with each other. And where I see that most acutely is when we get flagged for medication issues. We will find members that are on multiple chronic care management plans where you have to sign with a provider that this is the only pain management plan that you are on. So I'm sure each one of those doctors is very conscientious about what they're doing. But from a global perspective, this care coordination is not happening. And, you know, when you deal with your own sort of specific interests representing your specific stakeholder, don't lose sight of that global problem that's out there. You may be doing a good job or think you're doing a good job at your own point of care. But from where I sit, it's not happening.
Clarify.
We spent about our budget for next year is $160 million on health care. Providing the benefits for the, we're plan sponsor, yeah.
Got it.
We provide the benefits for those members of ATU Local 689 that are employed or retired from the metro system. Okay, about 12,000 belly buttons. Or 12,000 doorbells. Probably about 25,000 belly buttons.
And you have an insurance company administering the benefit for you?
We use Care First for 2 of our plans, and we have Kaiser for 1 of our plans. So we get into a lot of these HIPAA issues that you're discussing, Care First, we are the covered entity under HIPAA, so Care First is our business associate, whereas Kaiser is also a covered entity, and that's a different relationship. And then we also have to deal with issues of churn and people moving back and forth between health plans and some of the complications that creates. So that's all I want to say. Yeah. Just don't lose sight of the big picture.
Appreciate it, and thank you for sharing that. And all of us know people and our friends and family members who have experienced the kind of frustration that you're describing with a number of physicians, all who get up in the morning trying to do the right thing, but they're not talking to each other or coordinating what they're doing, and the patient's bewildered and overwhelmed. And it's good not to lose sight of that. That's one of the things we're trying to work on, and a lot of people are working on it right now, but we haven't solved it. So thank you. Anybody else? Yes, Lenny.
Thank you. Lenny Preston with the Maryland Women's Coalition for Healthcare Reform. I'm going to put that on first, and thank you all for the work that you've been doing. It's really fascinating and very constructive, I think. My other hat then is as chair of the Consumer Engagement Task Force with HSCRC, and I just wanted to respond to some of the conversation. I have put in for a magic wand because I think the only thing here really to do is to wave fairy dust, but short of that, we have a great work group committee that is looking at these issues. We've had 4 meetings. We've broken the larger group down into a subgroup just really focused on this. I should say that while our targets are looking at the new all-payer model targets and that audience, we really do see this within a much larger context because we can't just educate in one area. We really need to look at the big picture. So, and to engage consumers, you have to engage everyone. So one of the processes we're going through at this point is looking at all of the audiences and breaking those down. So those audiences, as defined, are both recipients of the message, and they're also messengers. And often they may be the same, and they're working in two dynamics. And we've got now about 2 pages of audiences. To speak to the public health, the local health departments are in there. Looking at the San Diego model that was brought in, the DSS offices are part of that, because if we don't look at the social determinants of health as part of this, I don't think we're going to get very far. And so we'll be working through that process. The next meeting of the work group is next Friday here at 9:30. In April, I think it's April 10th, this subgroup that's working on audience, messenger, and so forth is going to report out to the full task force. And so I would encourage anybody who's interested to come and hear the conversation to participate, to send information to HSCRC or to me about what you think we should be looking at, or if you have a magic wand, send it my way. It's been a very exciting process from our end, and we realize it is a huge lift, a huge lift. Yeah.
Well, thank you, Lenny. I can assure you that if any of us discovers a magic wand, I haven't. I've been working on this a long time. We will share it.
Thank you.
You promise to do the same with us.
Yes, of course.
In fact, I have a question.
Yes, Mark.
So one thing that I think you've heard around here is a concern that the straight Medicare fee-for-service community may or may not be accepting of the $8 per month care coordination fees that they're going to. Is the consumer work group looking into that? Because I think if we get a 60% opt-out in this state on the straight Medicare fee-for-service, then we're really going to be challenged with making this work.
Well, that's an interesting point, and we will take that back. Yeah, and Don is writing it down right now.
All right. Thank you,
Thank you.
Lenny. I'm sorry. We have one more person. Thank you. Come on up, and then we'll have to, I think, draw to a close.
Hi, Tracy Amo, Health Facilities Association of Maryland. Just a general comment. When you're prioritizing your buckets and your activities, to not lose sight of connecting providers into CRIS, not allow that to fall too far down the totem pole, because for providers that aren't connecting right now through a number of barriers, no matter how successful you are at developing data infrastructure and connecting providers, in particular for long-term and post-acute care providers that have to develop a care plan for every single patient, if that doesn't end up showing up on CRIS because they're not connected, you're missing out on a key element in managing their longitudinal care plans, especially since this population that typically has multiple chronic conditions. So just a general suggestion to not lose sight of that bucket, making sure that you're keeping that community, that population involved, and ensuring that there are some focus, because I see funding source TBD. So I want to make sure that that stays on your radar.
Thank you, Tracy. Tell me again your organization. I know you were here.
Yeah, I was here for the panel. Health Facilities Association of Maryland. We represent 150 long-term care, post-acute care providers in the state of Maryland.
Yes. Well, thank you, and thank you for coming last time and,
yeah.
and again reminding us today. Madam Chair, back to you. I'm sorry.
Sorry, quick comment in reaction to that. So representing the clinical committee of CRISP, which would probably look at this use case, we do need to think through how data moves in an already connected entity to CRISP, and for those that don't. And I think when we talk about this concept of a care profile, it needs to be as broadly constructed to facilitate the import of information from places that don't have already tight integration. So I think that's an important point for everybody to remember.
Thank you.
Thank you to all of the members of the work group. Next steps, as you have heard, we will schedule a meeting. We will do that around your calendars and do it in a way such that we can make certain we've got maximum participation, where you will receive a final draft with interims having been shared in between and final budget numbers. With regard to the information that needs to go to the Commission, perhaps you will allow Donna and I to be artful together to understand the language that needs to be before the Commission that continue to allow us some flexibility to complete our work prior to getting a final sign-off from the Commission. So perhaps with Steve's help, we can see what kind of artful language we could do there. Anything else before we adjourn?
Well, just that we do have a webinar on Tuesday about the regional collaboration grants, just to raise awareness that there is we're having a webinar just to explain the process. Ideally, we would have been done with the work here before that process really kicked into gear, and we will be done our work here before it actually starts. But people do have to start the proposal process now for that. And I'm looking for Steve because I don't have on the top of my head what time that webinar is on Monday, on 3 o'clock on Tuesday.
The webinar will take place at 3 o'clock on Tuesday. All the information is available on the DHMH and the HSCRC websites. The due date for the applications are April 15th. So what Donna was saying, we intend to award around May 1st. So that's just put the timing into perspective.
And just a reminder that that funding is a subset of the total BRFA funding that we're talking about too, is it?
2 or 2.5.
2 to 2.5 million of the potential $15 million pot is in these regional opportunities that will be discussed on Monday. Thank you. Anything else for the good of the cause? If not, we're adjourned. Thank you so much.